approve. Any comments, changes, corrections, additions, deletions? Do I hear a motion?
So moved.
Second. All in favor?
Aye.
Opposed? Great. All right, we have liaison updates. Brenda, do you have anything?
Not today.
Kirsten?
Yes, I do. With my notes, I just wanted to mention, thank you. 2 items. That High Talk is, sorry, make sure I get this right. High Talk is updating its strategic plan. We'll be making a 5-year plan this time around, which it's great, and I just wanted to add that the definition of health equity can come at a better time. And I think as committees are making these visions and plans for their next 3 to 5 years, it's really important that we figure out how we not only define health equity, but how we continue to implement and apply that lens. So just wanted to underscore that. And then wanted to flag that the prescription drug monitoring program is just going so well. And the benchmarks that we set for this year are going to be surpassed by exponentially. Providence and Legacy are adopting it, and so we have just tremendous penetration. Next, meeting, we kind of have met future benchmarks already this year, so we're doing a great job of it.
Good, thank you. John?
Well, we're on the agenda.
Okay.
And I think
Okay,
we'll have lots to discuss.
great. Rosinda?
Thank you. The Health Committee meeting committee has been having different committees come in and give updates and reports. And the last time we had the committee that Brenda just spoke about, High Talk, and then the Public Health Advisory Committee, and they've been going to do that probably until we complete the whole committee reports, and also we'll be electing co-chairs at our next meeting, or 2, their terms are up, and I believe one, I'm not sure which one, is not going to put the name back in, so we'll be taking nominations.
Okay, thank you. David?
An update from FAB, where we reviewed the definition of health equity that was approved by the board during the last meeting, which was the board meeting I couldn't attend. I apologize. We had a fair amount of discussion. The definition's up there, and the discussion was based around what a health system is, and it defines health equity with respect to the health system. And while we raised the concern that health system from the FAB's perspective includes the entire health system, including the public health system, which is especially important since health equity is largely determined by social determinants of health, which live outside the health care delivery system. And we just wanted to make a footnote that as we discuss this, that we are intentional about describing the health system as the health system at large rather than the healthcare delivery system, which may not be obvious to the CCO world or other people in the care delivery system. So as you discuss this, please make that footnote, Rebecca. Yeah. Our FAB chair, Rebecca Teal, here to cheer this on. And while I have the mic, I also want to just make a note. 1 week from today, November 12th, Zika Manuel is coming to speak to an OHSU-sponsored lecture on the future of healthcare reform. I'm reading his book now, The Prescription for the Future. And it is amazing, and it really frames the work we're doing. So I just want to put a plug in for that and invite you all to that lecture.
So did you want an action or just
I
something?
think we discussed changing it, but no, we don't want to change it. We don't want to redo it. We just like maybe a footnote or some type of record it in the minutes here, and then continue to remind ourselves when this comes up that we're talking about the health system at large.
Okay, thank you.
Carolyn?
John?
I think there may be other suggestions along the way. I mean, in some of the back and forth at HPQMC, one of the members asked, well, shouldn't age be in there? And it's not. I don't know whether it should or shouldn't, but I think there may be a number of clarifications that we would want to pass on at some point.
Right. You know, I think the conversation that we had last time was a really good conversation and understanding for me. It was very enlightening to understand the difference between health equity and health disparities, and that I think sometimes is a very gray line. It was one of that discussion. So when we talk about things like geography or age, I think sometimes saying there are health disparities related to based upon geography or based upon age versus the health equity. So those certainly can intersect, and that we should always be conscientious about that. But for me, that was an enlightening part of our conversation at our last meeting. So I don't think we're forgetting that. It's just that I think this definition is more specific than if you were to talk about health disparities, which I think is a wider discussion. All right, so the Oregon Health Policy Board Committee Digest is in your packet, so just want to make sure that you have an opportunity to take a look at that just for any other details. So with that, we shall move on to Pat.
Thanks. A couple of things, and I'll also mention things to Jeremy to talk a little bit about Senate Bill 889, but just in terms of CCO contracts and that work, I think I already reported to you that all 15 CCOs have signed contracts. The member transition process is, the first wave of member transition is now underway, and members have until the middle of this month they will have received notice of any kind of a change in their coordinated care organization if there's a choice available, and have the opportunity to change that. Just as a reminder, again, at the first of the year, they'll have 90 days of an opportunity to make a change. That's in anticipation of the notion that most people probably won't engage with this issue until the first time they're going to get care. We have continuity of care built in so that they'll be able to see the same providers. So that shouldn't cause that kind of a problem, but they'll then get that second window to make a change. So far, we're not seeing kind of a wave of chaos or those kinds of things, that with as many movements as there are potentially in this system that you might be afraid of. Personally, I kind of put that on the not so much that we're doing a stellar job, although I think our folks are really working hard to make sure this is smooth. But I think it is that notion of people don't know what's going on until they try to access care. We do have now updated network reports as of last Friday, and we're digesting those to see if there are changes that need to occur based on who does or doesn't have whatever providers they do or don't have. And we'll go ahead and make those changes as appropriate. So basically, we're kind of just generally moving forward on all fronts. You've seen the news, no doubt, that Trillium has entered into legal action with respect to the 3 hospital systems in the Portland area, and as things sit right now, we're kind of a bystander to that process. We're not directly involved, at least not yet, not at this stage. Couple of other things to note. Just finished a round of internal agency town halls where we digested the feedback that we heard from the community engagement process we've used for our agency strategic planning process. I can't remember if I talked about this before, but we really focused that engagement on underserved populations. We used our community partner outreach program to really consciously design appropriate kinds of opportunities around the state, 20 different sessions to gather input from people that we don't engage with or listen to very often. We created a digest of that input and then shared that input with our own staff, several hundred staff members over a series of about a dozen internal town halls, and kind of put a question to them of, after having set up the whole notion of we're going to focus on equity with the strategic plan and this engagement is the populations that we don't serve very well and that have the greatest amounts of health inequity in terms of data. So here's what they're telling us. Based on what they're telling us, what do you think we should do differently or change or invest in response to that? As much as it was intended to gather that input, it was also to begin to provoke people's thinking about, what this plan needs to be is about not doing what we've been doing all along that self-evidently isn't working in terms of health equity, and really get people into a headspace of thinking about how to change. And I've been really happy with how those conversations have gone. People have gotten engaged immediately and really dived in. So that's been really useful. Last thing I'll give you a heads up about before I turn it to Jeremy. We've now completed the rulemaking process related to CCO 2.0, which is probably one of the biggest bodies of rulemaking the agency has done since its inception. That includes financial oversight rulemaking. It does not include rulemaking related to mergers and acquisitions, and that's a body of work we're going to need to engage with you on over the next probably 3 meetings to begin to flesh out standards and requirements and those kinds of things, as we do likely have some pending work in that space. I'll go ahead and turn it over to Jeremy for Senate Bill 889, and then between the two of us we can take any questions.
Great. A couple quick updates. Since the last meeting, the governor appointed 18-member implementation committee for the healthcare cost growth target. And just as a reminder, that's a committee of the board, so they'll be making recommendations up to the board next summer and then ultimately to the legislature by September. Broad group of folks, and I know I've sent around the list, but we're really excited about a really good group of folks who, in talking with all of them, are really excited and committed to this work. So excited to see that work move forward. She also emphasized really 5 specific areas that the committee focused in on, really making sure that they pick an aggressive target that contains costs for families and businesses, utilize the existing data sources that the state has, like the All Payer All Claims database, to really ramp up transparency on what's driving cost. Looking at how this group's work and the target can fit into other rate setting or cost work that the state does. Examples of that are Medicaid rate setting and public utility rate negotiations and DCBS rate review. I want to make sure that this program complements and provides additional information to those areas of work. That we not lose sight of quality, in particular focus on disparities and inequities. And then task them with really bringing back some robust accountability and enforcement measures. So I think as folks will recall, the bill basically stands up the program that calls for a second piece of legislation in 2021 around what's the enforcement and accountability look like for organizations that aren't meeting the target. The first meeting is November 13th. We should have the full schedule out through next summer shortly. We've got November and December nailed down. The second meeting is December 12th, and we're really close to finalizing the rest of the meetings throughout next year. But they're open to the public. They'll be in this room. They'll be live streamed. All board members are welcome. I know you may want to talk about a liaison here in a second, but I would encourage anybody who's interested to follow along, and I suspect we may have some legislators that do the same. The first meeting is November 13th, 9 to 12. Let me just reflect a little bit. I had an opportunity a couple weeks ago to go back and visit Massachusetts and Rhode Island, and Pat and I both had an opportunity to make some rounds with delegation and others in DC around this. So you'll recall part of this program includes, this is really sort of transparency on steroids, if you will. That there's a big piece of this that's really around an annual cost trends hearing, where we're bringing together stakeholders and bringing together different parts of the state that have their hands in cost containment to understand what's driving healthcare costs and what to do about it. So Massachusetts does a 2-day annual cost trends hearing. I had the opportunity to go back and watch that a couple weeks ago. I'll send around a couple photos of folks, but I'll just say my kind of takeaways from it. This is their 7th year doing it. and where they've really, where this is really led to is a forum where they're really aligning across the executive and legislative branch and across a broad group of stakeholders and really setting, frankly, the healthcare agenda for the next year. So had Governor Baker came, the Attorney General came, the Speaker came, the Senate President came, all gave their perspective. There was 2 days worth of panels of stakeholders from pharmacy to hospitals to health plans to providers and consumers, each diving into what the challenges were that they saw and talking about where the focus should be in the next legislative session. So it was a packed room, probably a couple hundred folks for the 2 days. Really interesting experience, and I'll send that around. I think just again talking with to David Seltz, who runs the Health Policy Commission, which is somewhat analogous to the Health Policy Board. It's taken them 7 years to kind of get there, but I think it does paint a picture of where ultimately this program can go and how it can really bring together folks both from executive and legislative branch around a common agenda. I also had the opportunity to go down and talk with folks in Rhode Island who are in the midst of launching their own benchmark program, and I'll just say lots of lessons learned as several states are sort of embarking on this. We're going to stay in close contact with Rhode Island and Delaware and Massachusetts, and there's several other states that we know are looking at this as well, and might be a collaborative coming together pretty soon of those states so we can all kind of learn from each other. But I think folks are, Rhode Island and Delaware did it through executive order, and I think are a little jealous that we had to build it past, which gives a little bit more teeth to it. And I think folks will really be watching Oregon closely as we're the next state to really unfold this. So that's my update.
Be happy to answer any questions you've collectively got on anything.
The other thing to think about is we have a new committee, which means we need a liaison. So think about who would like to be a liaison for that committee. Or I will appoint someone, or I've heard a new term, voluntold.
Don't miss it.
Right, don't miss a meeting.
There's no, if I remember correctly, there are no legislators appointed to the committee, is that right?
That's right.
And is there any formalized legislative relationship to the committee?
Not in the bill. We there's a lot of legislative interest. So in September, we made rounds with most of the whole House Healthcare Committee and Senate Healthcare Committee, and folks are really actively engaged in this. And there's a good group of folks that want to stay basically apprised on a monthly or very monthly basis. Representative Nose and Senator Beyer were the leads through the session. I know are going to be tracking it really closely, but there's a lot of legislative interest.
Great. And staffed by your office?
Staffed by my office, we have a consultant on board, Michael Baylett from Baylett Health, who helped Rhode Island and Delaware. So they'll be providing a lot of the subject matter expertise and helping facilitate the meetings. We're close to hiring a policy analyst that will help us stand the program up, and that position will continue on until implementation.
So, Jeremy, how do you see this cost containment committee coming together with this effort to bring the non-CCO sector of the healthcare delivery system together in Oregon?
I mean, overall, I see this as extending our transformation efforts and focus on costs much broader than we have today, which is, really started with CCOs and Medicaid, have broadened it out to public employees, and I think this really is the next step of really bringing in the rest of the health system. The makeup of the committee includes most of the health plans, the commercial health plans in the state, and several hospitals. So while all those folks also work in CCOs and the Medicaid space, it's a conversation that's much broader than Medicaid. And ultimately, I think we'll replace the 3.4% that we have because that expires in 2022.
Other questions? Comments? All right, thank you, Jeremy. So is Julie and Jackie here?
Julie is, I don't believe Jackie is yet.
morning. Good morning, everybody. Hi, is that
The button.
Oh, good morning, everybody. Good to see everyone again. Again, my name is Julie Johnson. I'm the Tribal Affairs Director for the Oregon Health Authority. We had invited Jackie Mercer to be here today. She's the CEO of NARA, the Native American Rehabilitation Association. They've been going through some emergency stuff this last week, and she is unable to be here right now, so I apologize. I should have called her this morning, but I was just texting her right now. So I would love to be able to have the chance just to give a quick update on tribal work and then ask to have her back at another time if that's okay. So I do apologize for the very late notice. Sometimes things just happen. We have to deal with them. So just
Before you dive in,
Yeah.
since we're going to be moving our schedule up a bit, so if anybody has public testimony, please sign up now, because when Julie's finished, we'll do public testimony, so.
thank you, Carla. And I definitely don't want to try to talk on behalf of NARA because of the amazing work that they do here in the Portland metro area. But just a couple of things I would love to just give you an update on as far as tribal affairs work goes, especially in regards to CCO 2.0, which I know a lot of people have been spending time and energy on. We've been working on the tribal liaison position that will be at CCOs, and that position will be connected with our tribal advisory council. So all of the tribes are sending representatives that will sit on that tribal advisory council, and then we're working with all of the CCOs to have a tribal liaison. And this is a huge piece for us, just moving this work forward, having those connections at each of the communities, and really trying to kind of build some relationships or rebuild some of those relationships that haven't always been, 100%. And so we're looking forward to that work. Just a quick update on the Indian Marriage Care Entity, which I think we've talked a little bit about. We've had 2 responses from tribes so far that have said that they would definitely want to continue to move forward on that. We're trying to figure out what enrollment would look like for that, and so we've got like 4 different options. And so we gave them the deadline of November 12th to get back to us. So we just really want to know what tribes out of the 9 will want to be moving forward with that. Also, the Urban Indian Health Program could potentially do this, and even Chamawa Indian School could do it if they were interested as an IHS facility. So that's some exciting work moving forward. Just thinking off the top of my head, 100% FMAP are claiming for a federal match. We still have 7 tribes utilizing that program out of the 9, so that's great work. Just lots of good stuff happening with tribal affairs, and we've got a couple new liaisons coming on board, not full-time liaisons, but people designated in the different divisions to just assist us with the work and moving forward. So again, I really apologize for the agenda mishap, and hopefully we'll be able to have Jackie back. Does anybody have any questions?
Questions?
Julie, could you just take a minute and talk about kind of the pace and flow of consultation work? I think
Sure.
that's really an exciting story across the agency.
Yeah, for sure. So I can't remember if I talked about it before, but we passed a new consultation policy last March 2018, and it's a really robust, thorough policy. Our old policy really just covered Medicaid work, so things like state plan amendments, waivers, SPAs, state plan amendments or SPAs, waivers, rulemaking for Medicaid programs. And so the tribes, OHA had done some things without consultation to the tribes, and some big kind of policy changes and program changes, and so the tribes had asked us to revamp our policy, and so they actually helped write it. They drafted it with the help of the Northwest Portland Area Health Board, and so now it covers all things that we do at OHA: behavioral health, public health, Medicaid, anything and everything. So over this last year and a half or so, we've been really working hard to fully implement that policy. Last year, so the process we have now is identifying what we call critical events, which could be a program change, a policy change, a rule change, maybe new funding, maybe a new report or data piece that we're working on. Anything that can really impact the tribes, we identify that as a critical event, and then we use the process of a Dear Tribal Leader letter to communicate with the tribes of what that changes, how it's gonna impact tribes, what's the time frame on it, and so we offer consultation with the tribes to discuss that situation. And really, you know, consultation is about coming to the table and having a discussion, not with changes already made or not with ideas already formed, but really, you know, this is our thought, what do you guys think about it, how would it impact you, you know, how can we work together on this? And so the first year, we sent out 22 Dear Tribal Leader letters, and I think we had a total of about 7 consultations. Sorry, I don't have that numbers in front of me, but this year, so far to date, I believe we've sent out about 36 Dear Tribal Leader letters, and we've identified, I think 3 or 4 pieces of consultation, but then the tribes have asked for consultation as well. For example, the CCO 2.0 rulemaking, we actually had 5 consultation meetings just on that rulemaking piece. We're getting ready to do now the behavioral health rules, so we know we'll have at least 2 or 3 meetings on that. We just did a consultation on strategic planning, and we're getting ready to do a consultation on the dental pilot project rules. So it's really been a great opportunity for OHA to clearly define consultation, because that wasn't clearly defined, even though it has been state law since 2003 that every state agency has a policy. Not all state agencies have a policy or implement it, and so we've been doing that, and then the process has really helped too. For example, when the vaping stuff happened, because we had that process set up, we were able to get a Dear Tribal Leader letter out in like 2 hours, versus, you know, what are we gonna do, who are we gonna contact, how are we gonna communicate, all of that stuff. So it's just been really, really helpful to follow that process. And so now lots of other state agencies are, you know, looking at our policy and our process on how they can improve the work with tribes. So it's a lot of work, but it's really good, important work. So I'm just glad we have that.
I just wanted to compliment Julie and her team on that consultation work. She said it's a lot of work, and that vastly understates it. It's great to make sure everybody in the agency knows that they need to trigger a Dear Tribal Leader letter. It's another to actually be the ringmaster for that sometimes circus of work. And Julie's been doing an incredible job, and just, you know, it's really, I appreciate having a relationship today with our tribal partners that's not based on apologizing for not having included them and not having shared information and not having consulted. And it's really a much better place to be. So thank you, Julie.
Yes, thank you, Pat.
John?
Yeah, I just wonder if we could eventually get some feedback on the tribe's reaction to the equity definition.
Oh, great, yeah.
And how that is. You know, for myself, you know, I'm interested in the injustice issue, and you know, how from a health perspective, health can try to repair that. You know, I listened this morning to NPR had stuff on the Chinese, and we treated them awfully back in the day. So we've treated a lot of different groups of people in awful ways, and that injustice term in there, I think, was great, that it's challenging.
Yes, thank you. I really appreciate that. We actually shared the definition with the tribes, and we were really happy. People were really happy to see tribal governments called out on that. That's so important to us. Just again, recognizing that government to government relationship, but then it really is about the injustices, right? Like I talk about all the time about why Indian people have the health disparities they have, what I believe, you know, what I understand, and my perspective on it, but we need everybody to kind of learn about that, and then what are we doing about it, right? So the numbers, the data, it's been there for a really long time, and we can all talk about the why, but what are we doing now to improve that? And I'm really happy with the work right now around health equity, and just with the definition, again, defining things is really important, right? And so everybody can be on the same page, and then how we can move together, move forward on that. Thank you.
Rosinda?
Thank you. I just wanted to mention that the Umatilla tribe was able to comment on the health equity definition from our legal standpoint, and also from the community standpoint. So, and I think that other tribes had that same opportunity, but it seemed like you kind of bring up some things, and then yet sometimes they don't quite get to where you want them to get. And so I think that happened with some of the tribes. I know my tribe had that opportunity. We took advantage of it in the Health Equity Committee. So very pleased that we did make comments and were involved.
Thank you.
Okay, thank you.
Yeah, I'll work with Jackie to get rescheduled for you guys.
Okay.
Thank you.
Great. Okay, I'm going to put Jeff on the spot.
We don't have any public testimony signed up. I suggest we do our break now.
Well, so what I'd like you to talk about is our meeting next month.
Oh, great. I'd be happy to talk about our meeting next month. I'm sure we can sit and see.
Since we have some time.
At the board's request, we are continuing our out-of-area visits. We've done a lot of out-of-area visits. We started out at Lakeview, and that really inspired the board to get out a lot more than our statutory requirements. The last one for the year will be behavioral health focused 2-day event. We'll have some time to tour the state hospital and meet with behavioral health advocates, stakeholders, subject matter experts, and systems. And then we'll have a board meeting the next day, typical as we usually do for the board, and we'll have a deeper dive at that point about vision, behavioral health policy and infrastructure, challenges, opportunities, and barriers. Steve Allen and Dolly Matucci will lead those conversations from the agency's perspective, and it'll be a good chance, I think, for the board to get both a comprehensive overview of the behavioral health system, kind of like maybe a 101, 102, maybe even a little bit into 201, maybe a little bit into pushing the board kind of harder to get more and more familiar with Oregon's behavioral health system. I think that this is also in response to a request by the board to hear more about behavioral health and maybe see the state hospital. I think it's the first time that the board's had the opportunity to visit the state hospital. I don't know of any time in our history where we've had it. Zeke has a correction for me.
We were there 3 years ago.
3 years ago, the board was there. Thanks, Zeke. Is there any questions about our behavioral health focus meeting coming up in December? The meeting itself will be at the ODF&W building. We'll of course supply the address and your calendars and have agendas out beforehand. And if there are any other specifics related to behavioral health that you're thinking of, feel free to shoot me an email to make sure that we can capture them.
Great.
Jeff, mental health and the tribes.
Great, yeah, we're working on that too. Julie and I have a monthly confer at this point to make sure that we're setting the board up for continuing ongoing education and opportunity to discuss tribal matters with tribes. So we've discussed this one as well. We kind of want to see what the best update to bring before the board is. We're debating right now between a local tribe from the area coming forward, or maybe a review of the behavioral health strategic plan for tribes. But there'll be a tribal component.
Are the tribes involved in the state hospital in some way?
That's a great question.
In terms of input? Or?
That's a great question. I'll have to dig a little deeper and get an answer.
Okay.
Yeah.
Yeah, see.
You may already be thinking about this, but I think just that interplay between community-based mental health services and then the kind of infrastructure that's built out at the state hospital, and as we're continuing to try to move more and more towards community-based services, like what does that look like between? So getting perspective both from a community perspective and from state hospital, potentially in dialogue, would be, I think, a really interesting way to think about that particular issue.
Yeah, and so the board knows that's kind of exactly the angle we're taking on it, is how do we have both of those conversations about both of those topics in a discrete way and at a board meeting.
All right, so all day Monday and then a half day on Tuesday. So that's your market calendar.
All day?
That's my understanding.
All
That's
day?
right, that's
All-
right. All day Monday. Usually, I think it's a half day the day before, but it will be an all day event the day before, so that we can, behavioral health is not a small topic to cover. We have a lot to share.
I've heard that.
Yeah.
Jeff, I just say, I know these are a lot of work to organize, and everyone you've done, the whole team has done has been flawless, and so thank you so much for putting the extra effort in.
Great, thanks for saying that. That gives me an opportunity to say really clearly, publicly for the board, there are so many staff at OHA and around the state that go into making these happen, and I'm just one tiny little piece that gets to sit up here and tell you about it, but there's just a lot of people in the background, dozens if not hundreds, making stuff like this happen, so thanks for the words.
And we appreciate it.
Yeah.
Road trip. Okay, so we're gonna take a break because there's no public testimony. And let's plan on about 15 minutes. We anticipate Chris will get here, but when you come back, we still may have a little bit of time. So, all right, thank you.
We may switch up the order. So who's available?
Okay.
bagel seeds towards you. In case I'm not, little bird-ish. Those were junk. We already had a collection of them, too.
All right, so we're gonna get started again. So the plan is that we will talk about the CCO measure performance structure. Then Chris DeMars will be after that. And then we will end with the metrics and scoring committee information. So we have our next group ready to go. So if you'd like to introduce yourselves and dive in.
Good morning. My name is Stacy Schubert, and I am the Director of Health Analytics within the Health Policy and Analytics Division in OHA.
Hello, good morning. My name is Valerie Stewart, and I manage the metrics programs as well as the evaluation waiver for our demonstration.
Hi, I'm Sarah Punchman. I'm the lead staff for the Metrics and Scoring Committee, so I work on Stacy and Valerie's team.
So I will get us kicked off and give you a little bit of an orientation to the program overall, and then turn it over to Valerie, and then Valerie will turn it over to Sarah. And then we'll round it out with a little bit of a discussion at the end of our presentation if we have time. So the Quality Incentive Program for CCOs is an integral part of health system transformation for Oregon. It was built into our 2012 to 2017 waiver. It's built into our 2017 to 2022 waiver. And it's the method by which we implement pay for performance for the CCOs. It's been in existence. It's actually been in effect since 2013. By next year, it will have been in effect for 8 years. Over the 6 years during which we've paid incentive payments thus far, we have paid out almost $850 million of incentive dollars, averaging about $140 million per year. So this is the largest lever, one of the largest levers that OHA has to help ensure quality and to pay for performance for the CCOs. Over the life of the program thus far, there have been a variable number of incentive metrics for the CCOs. For next year, there will be 13 incentive measures. Last year, or the year that we're currently in, there were 19. So that's actually the range, the lowest and the highest. And the other years have been in between those two numbers. An independent evaluation has shown that those incentive measures lead to much greater improvement than metrics that are not incentivized. And you probably all know this, but there is an independent metrics and scoring committee that selects the metrics and also determines what the targets are in order for CCOs to earn incentive dollars. So that's a very brief overview, and I'll just give you an overview of what the presentation, what we'll talk about. So we'll go more in depth on the CCO metrics. We'll talk about the incentive program, just a level set so you understand how it's structured and what the governance is. We'll do an overview of the most recent performance. We'll talk about developmental measures. And then, as I talked about earlier, we'll have hopefully time for a discussion. I'm going to turn it over to Valerie.
Okay, thank you, Stacy. So I'm going to talk about the sort of general overview of the incentive program that I manage. As you know, the CCO incentive metric program is probably the most well-known of the metrics that my team tracks every year. In 2019, there are 19 incentive measures that are being measured in this year that will be reported out in June of 2020. A secondary type of quality metric that we track are called the state quality metrics. These are measures that are reported as part of our demonstration waiver. In the current demonstration waiver, we have 35 of those. And then finally, CMS, the federal agency that oversees Medicaid and Medicare, requests that we submit to them every year core metrics of quality that we submit at basically the end of the year through a secure portal that's reported for all 50 states. So the reason there's a Venn diagram here is because if you summed up all the different subcategories of the measures, you would come up to something like 90 different unique measures. But in fact, because we try to leverage a single metric for multiple programs, we really are tracking about slightly over 60 metrics every year. And so that just shows, I think, sort of an overview that there is much more to quality measurement than just the incentive measures. So OHA remains accountable to CMS through our state quality measures in the 2017 waiver, the agreement that we have with CMS. And so, as I said, performance is measured on 35 of these metrics to basically ensure that while we're conducting transformation with healthcare delivery, we're not in any way jeopardizing delivery quality for the members. And so in our prior waiver that ended in 2017, went from 2012 to 2017, there were actual penalties involved. If the state quality measures degraded, the state of Oregon would have to pay CMS for these penalties. Fortunately, we didn't have to do that. There were no penalties involved. And for this waiver, they've done away with that aspect entirely. So, yes?
Can I just add one piece of context there? So I think folks will probably remember from 2012 to 2017, the federal government gave us basically an upfront investment to start CCOs. And part of, there was two components of some of those dollars were at risk for both reducing costs and for improving quality. So it wasn't that they had a penalty just on the quality side, it was that we actually had a penalty on the cost containment side. In other words, if we didn't meet the 3.4%, we would have had to repay some of the dollars. But there was a concern that that would cause such a focus on cost containment, you would lose the quality piece. So they coupled it both and put the dollars at risk, both for quality and for cost. But those dollars have now ended, which is why there's not a financial penalty.
Yes, thank you. My focus is almost entirely on quality, so thank you, Jeremy. Okay, so the next slide shows the accountability OHA has to CMS, the federal agency. And these are for both adults and children populations. And right now, states are allowed to choose from a menu of measures and report the ones that they've calculated to CMS. And then CMS puts out an annual report of all 50 states and allows people to do comparative analysis of all the states. However, beginning in 2024 for measurement in 2023, they are going to have a subset of these measures be mandatory, and it will be required reporting for all states. And that's, so we're sort of looking out and preparing for that. So the CCOs are accountable to OHA through the incentive measures. As I'm sure you've all heard about this particular program, which is an annual assessment of the CCO's performance and is tied to bonus payments. Beginning in 2020, the arrangement will be changed to a withhold arrangement. Over the years, historically, the Metrics and Scoring Committee has selected, there's a typo in there, 17 to 18 measures typically. There have been 17 to 18 measures that have been on the incentivized list. And in 2020, which has already been selected for 2020, they've reduced it to 13 measures that will be incentivized. There's also, in addition to the quality pool payments, there's also a separate challenge pool of dollars for extra payout for particularly challenging, that's why it's called the challenge pool, measures for the leftover dollars that were not paid out from the quality incentive pool. In 2018, that we paid out in June, just recently this summer, the payment totaled $188 million for all of the CCO payments, quality and challenge pool.
Will the challenge pool be continue after 2020 as a part of the withhold?
We've had extensive conversations with our financial experts, and yes, it will be continued in 2020.
As a part of the withhold? Like, is it?
No, not as a
separate?
part of it, it's a separate pool. It's a separate, totally separate program. They've been disengaged and have different vocabulary to describe them.
Yeah, short answer is yes. We just have to work
Yeah.
through some technical details on how we get there.
Yes.
But it'll still be part of the program.
Still there.
I have a question.
Mhm.
So can you describe for us the CCO's reaction to the shift to a withhold, number one? And then my second question is, if the reduction of measures from 19 down to 13, the relative value for each measure has then increased. I'd like to hear or understand a little bit about the impact of that as well.
Mm-hmm. Yeah, I think that would you like to help me with that part?
I'll start with the second piece in terms of
Yeah.
the relative impact. So the way the program is structured, the CCOs have to improve care on 75% of the metrics. We don't pay per measure, so they can earn a certain amount. So in that sense, it's that group, it's not the per measure, it's the group that has kind of increased the value. And some of the conversations that the Metrics and Scoring Committee has had about reducing the number of measures is that in doing so, you kind of push the focus to the point that you're making, because relatively speaking, they're worth more. But do bear in mind, we don't pay per measure. We look at how they perform across all of the measures.
And I will say, one of the things that makes it particularly difficult in 2020 is that the committee did select 4 brand new measures that have never been measured before as incentivized metrics, and that makes the overall difficulty of achieving the quality benchmark and improvement targets a higher difficulty.
And were those new measures in developmental stages prior to launching for 2020, or are they just brand spanking new?
They are all standard measures. The new metrics that are up, 3 of the 4 are standard measures that are coming in. So they are things that have generally been tracked either in Oregon or nationally. So there are standard specifications that we have used. A 4th on preventive dental visits is on around kindergarten, and that's something that we have tracked previously. So they're not developmental in the sense we're going to tell you about some other developmental work that we're doing. They're not brand new that Oregon is developing. They are things for which there are standard ways that they are calculated nationally, and those are just going to be implemented as part of the incentive program from 2020 on.
When you say improve, does that mean improve year to year based upon the prior year, or does it mean meet a threshold?
It means improved year to year, and it's based on the distance from where their current performance is to the national benchmark. Okay, next slide, please. So in the demonstration, the Medicaid demonstration waiver, we had an independent third party, OHSU Center for Health System Effectiveness, evaluate the Medicaid demonstration. And they did find a significant changes on the measures that had been included in the incentive program as compared to those metrics that had not been incentivized. So this pointed to the effectiveness of transformation using the incentive program. And so in their summative report that they submitted at the end of 2017, OHSU evaluators said that we should really focus on the level of this particular program to affect transformation and change, and also to look at more care coordination type measures, and perhaps introduce new measures in the areas where we remain more challenged. So the next part goes into the structure and governance, and this is where I'll transition to Sarah, who knows a lot more about the detail level. So CCOs, when we talk about the benchmark on a particular measure, the benchmark is meant to be the gold standard nationally. It's meant to be an aspirational threshold that may be quite difficult to achieve, particularly in the early years of a metric. And so we also, the Metrics and Scoring Committee also selects an improvement target that each CCO must meet annually to achieve their incentive payment from the quality pool. So basically though, as Sarah just said, each CCO doesn't have to meet all the metrics. They just need to meet a particular percentage, in this case 75% of all measures, in order to get their full quality pool payment. So the funds that are in the quality pool are paid out every year, and the amount of the program percentage paid out has changed over the years, as you can see in the slide, from 2% to 2018, most recently 4.25%. And in 2019, when we complete that measurement year, the payout will be 3.5%. We believe that the financial team is already they're already on track to have a percentage increase in 2020. So it changes from year to year. And in the quality, yeah.
If I could just comment, that reduction is a decision that we made because the system overall failed to meet the 3.4% target. And so it was a question of what levers do we have available to be able to offset that. The idea hopefully is that we can get back on track to a higher portion of compensation being a risk.
I actually think that's a good point around why we moved to the withhold to begin with. There was really sort of three pieces to that. One, as CCOs were challenged to continue to hold the 3.4%, paying it as a bonus on top of whatever rates is becoming harder and harder. And so that was one reason to move it to a withhold, even though we're trying to do it in a budget neutral way. The second piece is there's a 5% cap at the federal level on quality bonus payments if you do it on top of your capitation rates, as opposed to a withhold. And then the third was really just trying to really implement this in a way that we've always talked about it. We've always said 8% of CCO's global budgets are at risk, but functionally we've always done it as here's your global budget and then here's a bonus payment as a side. So we're really trying to actually just bring this together more aligned with how we've talked about it the last 5 years.
If your mic is on, can you make sure it's not on while you're not talking?
Okay, so in the next slide, this is a table that shows the maximum 2018 quality pool payout that could have been achieved by each of the CCOs. And you can see that slightly over $188 million was in the quality pool for 2018. In this graphic, we try to show the flow of how measure selection happens with our public partners. OHA staff assists in this process from this policy board that advises and directs the Health Plan Quality Metrics Committee. As you recall, the Health Plan Quality Metrics Committee was tasked starting in 2017 to create a menu set of available metrics for selection by publicly paid health plans, including OEB and PEB, in addition to Medicaid. And they completed their first phase of their task earlier this year when they created a menu set of slightly over 50 measures that could be selected. Then the next step comes with the Metrics and Scoring Committee, which makes the final decision on which measures are incentivized and chosen for a particular year. And the arrows there are bidirectional because communication happens both ways, where the Metrics and Scoring Committee, which is a subcommittee of the Health Plan Quality Metrics Committee, may advise that committee and vice versa. And then finally, to the right, is our TAG group, our technical advisory group from all the CCOs. And this is the group that advises our team about the very, very nitty-gritty details, including things like coding and things that are happening on the ground about the metrics. And so together, these groups make up our metrics stakeholders that we work with. Okay, next slide. So the Health Plan Quality Metrics Committee was created to align the health outcome and quality measures used throughout the state and manage the number of metrics that each clinic has to be concerned about, because there's a proliferation of lots of different metrics at the clinic level. And also, of course, to continue with our transformation work for the health of all Oregonians and be accountable to improve health care. So per legislation, their work is to identify health outcome and quality measures that can be applied to CCOs and other health benefits that are under the state. And they evaluate on a regular basis. They will be doing it again in 2020. This menu set for either additional ones or exclusions of others. So they will set the menu set for the publicly funded health plans in the state for quality measurement. So I'm going to turn it over now to Sarah Kleinschmidt.
Hi, and as I introduced myself, I should have said I'm the Jeff of the Metrics and Scoring Committee, if that sort of helps to orient you. So this is where I get to start talking about the Metrics and Scoring Committee, which is the committee with which I work, and to give you a little more information on kind of their role and their scope. It's called out both in the legislation that established the committee as well as in our Medicaid waiver. So in the legislation that established the committee, they select the measures as well as the targets for the incentive program. When they became a subcommittee of the Health Plan Quality Metrics Committee, that legislation also actually calls out specifically that the Health Plan Quality Metrics Committee should take into account the recommendations of the Metrics and Scoring Committee, and also consider the differences in the population served, right, from PEB and OEB versus Medicaid members. And then the other thing to be conscious of is that in the Medicaid waiver, the waiver dictates that the Metrics and Scoring Committee, not HPQMC, not the Health Plan Quality Metrics Committee, and not OHA, selects the incentive measures as well as the targets. In the legislation, it calls out that there are 9 members of the Metrics and Scoring Committee, and it says 3 are members at large, 3 are members with expertise in healthcare outcomes, and then 3 represent CCOs. The director of OHA actually appoints these members currently, and we've throughout the years tried to ensure that there's representation both from oral health, from behavioral health, and ensure that there's that expertise on the committee as well. And in thinking through, as Stacey mentioned, we know that this is a really powerful tool in terms of pushing for quality improvements for our Medicaid members. And so the specific measures that are included in the program are really, really important. So this slide shows you on the bottom some of the things that the committee considers as it goes through and makes its decisions. So when they were thinking about 2020 specifically, they looked at the governor's goals for CCO 2.0, they looked at the Medicaid goals included in the Medicaid waiver, and they also looked to their measure selection criteria. They have agreed this criteria back in 2014, and it includes things like looking at program goals, hence looking at CCO 2.0 and the Medicaid goals in the demonstration, and also more technical things like if you're looking at a particular measure, are the data actually available? Can we actually collect this measure? They also have created a retirement checklist. So if they're considering retiring a measure, they can go through this checklist. It gives them some conversation points and things to consider. They consider past performance. They have they receive stakeholder input like you. They always have public testimony at all of their meetings. We've conducted stakeholder surveys. And then they also get feedback from the technical advisory group that Valerie mentioned. So this slide shows you all of the incentive measures that we have had since the beginning of the program in 2013. And you can see that in each year it's generally been between 17 and 18 measures. So if it's light green on this slide, that means it was an incentive measure in that year. If it's dark green, that means it was an incentive measure and it was in the challenge pool, so it got an additional focus, and they're usually between 2 and 3 of those in each year. And if it's white, it was not an incentive measure in that year. But you can also see in looking at this that generally most of the measures that have been in the incentive program to this point have stayed for quite a few years before retirement. And so now I get to talk about most recent performance. And so the next few slides are from our most recent report, which came out in July, and it looks at CCO performance in 2018. So on the left-hand side of the slide, you can see the total quality pool dollars that were earned by each CCO, and those are going to vary by the members that are included in a CCO. So for example, HealthShare would be eligible to earn more dollars than a smaller CCO. But on the right-hand side, I think this is more indicative of a way to summarize performance. This shows the quality pool dollars earned per member per CCO, and you can see some variance there. If we move to this next slide, this is our summary slide of performance, and I'll orient you to it. On the left-hand side, each of the rows, these are the 17 measures that were included in the incentive program in 2018. And the columns are the CCOs. If a square is dark blue, that means that the CCO not only achieved the measure, but it achieved that aspirational benchmark that Valerie talked about. If it's lighter blue, it means that it didn't achieve that aspirational benchmark, but it did improve performance, and what we call that improvement target that Valerie mentioned. And that means that from the previous year, it improved performance by at least, it reduced the gap between where they started and that aspirational benchmark by at least 10%. So if you look at this slide, at the very top, we have the access to care measure from our CAHPS survey, and you can see that there were 3 CCOs that achieved that measure in 2018. 2 of them in the dark blue achieved that aspirational benchmark, which was the National Medicaid 90th percentile, and 1 of them didn't achieve that aspirational benchmark, but it still improved, it reduced the gap between where it started and that aspirational benchmark by at least 10%. If you go down to the bottom of this slide, there was a measure on weight assessment and counseling for kids ages 3 to 17, and you can see all of those blue. So that means that all of the CCOs not only achieved the measure, they hit the benchmark, and the same for the patient-centered primary care home enrollment measure above that.
Is this an appropriate time to ask you about the EHR? So some of these measures say EHR, and I think that's an important point. I'm not sure that people understand what that means. Is this the right time to ask that question?
That's totally
Okay.
fine. Yeah,
All
I was
right.
going to pause here for questions actually.
All right.
So we have a variety of data sources that we use for the CCO measures. The majority of them are from Medicaid claims, so we will calculate those at OHA. We do have those that are marked as EHR. Those are electronic health record-based metrics. Some of them are standard measures that are used nationally, and others, like you can see in the middle, the cigarette smoking prevalence measure. This is a state-specific measure. The data come from the EHR, but as it is not a standard metrics, clinics have to go in and they will calculate those measures. They'll send the data to CCOs. They gather all of that information and send it to OHA to ultimately calculate the measure and the rate at the CCO level. And then we also have, currently there's the one CAHPS-based measure, though that has been retired for 2020. Does that answer your question?
Yes, and I already knew the answer, but the reason why I was pointing it out is because the challenge with the EHR measures is not everybody's on the same EHR throughout the state, which means that sometimes clinics have to have custom-built processes to capture these measures. And so if clinics are unable to do that, then they cannot be included in these measures. And so it really becomes a challenge. So I think it's just important to understand that. The claims-based is easier to capture because everybody's billing. But when they're EHR-based, it becomes, it really does become a challenge sometimes for clinics, so just.
And then, go ahead.
Couple questions to the point that Dr. McKelvey just raised. Given that 5 years from now, 70% of our spend will no longer be on a claims basis, what's our plan for gathering that data when that happens?
One of the programs that I manage in the metrics program is called the Clinical Metrics Quality Registry. It's a joint project with OHIT, and we're working really, really hard to improve our data reporting into the EHR at the patient level. There are over 40 different EHR software that we work with in the state. And at the present time, in every April, every CCO submits a data plan for how they're going to submit this EHR data. And right now, we're in the very, very early phases of being able to report out from EHRs, and the lack of standardization is an enormous barrier, and we're working on it as best we can, and the CCOs are helping us with that.
The other component of it is, so the Office of Health IT is launching the Clinical Quality Metrics Registry, which right now these are submitted in essence through spreadsheets so that we try to go back and try to validate. And the reason that the Office of Health IT has been building that tool is so that more and more folks can funnel clinical data, clinical measures into a central repository. So we'll be starting with CCOs, but the idea is that is a broader utility for the broader health system eventually, so that folks can connect their EHRs and other systems to it and have a central place where we can pull clinical data out of, or clinical data related to quality measures.
Second question, let's take a metric like colorectal cancer screening. And it's two parts to my second question. The first part is, I know because I've been using it as an example as I've been talking around the agency about health disparities. This metric is based on colorectal cancer screening by age 50, right? Versus age 45, which is the indication for African Americans. And are we doing anything to address that? Second part of the question is it possible when we think about these metrics to disaggregate them by race, ethnicity, so that right now when these roll up, you can basically not do anything to address any health disparities and still get the metric. Would it be technically possible for us to say, you don't get the colorectal cancer screening metric unless you have made improvements in each of the race, ethnicity, or other categories that we disaggregate into?
Sure. Well, I think, as you know, we are working on improving our race ethnicity data within the MMIS system. We certainly, when those data are filled in for more people, would be able to measure any of these metrics. And in fact, in the past, in previous reports, had reported most of these measures by race ethnicity, and then elected not to for this report because we knew that about 42% of the OHP members were missing race ethnicity data, and we felt that that wasn't filled out enough to really be representative. So certainly once the data quality is improved, and we do have some longer term solutions we're working on. And then we're thinking about some potential shorter term solutions as well if those longer term solutions take longer than we hope. Once we have those data, we absolutely could set goals or targets by race and by ethnicity. That would be a decision of metrics and scoring committee, though. We, at OHA, we can certainly show the data disaggregated in that way, but in terms of setting those targets, I think that would be a pretty big change, and metrics and scoring would need to participate in that.
The other thing that I would say about the committee, and this precedes me, it was under my predecessor. I know the Metrics and Scoring Committee did spend, I believe, a year discussing disaggregating these measures by race and ethnicity. And the real challenge there is the disproportionate distribution across the state of minority groups. And so holding a particular CCO accountable for, maybe what would be 25 members is really challenging when another CCO might have, 25% of that group in their CCO. So the distribution of minorities is not equivalent across all the CCOs, which makes it somewhat challenging to set it as an incentive measure, although the Metrics and Scoring Committee did explore that quite in depth.
I would just comment first to the data quality issue. Thanks for pointing that out. We did make changes to the MMIS, the one system, actually the one system, in, I believe, September. It's not quite been long enough for us to know whether those are gonna have a positive impact on the refusal rate. So we'll probably need another month to have a sense of that. It'll still be a modest change in that refusal rate. But I guess the larger point to make is that I do think we're gonna need to challenge metrics and scoring and ourselves to figure out challenges and all in terms of how to do that kind of disaggregation that we need to actually pay attention, because as you know, as we said a few slides ago, incentives cause changes in behavior, and by not trying to use that powerful tool to reduce equities, I think we're leaving an important tool unused.
Can I just comment? We'll come back to this because screening for colon cancer is now disincentivized. It's not the incentive measures. And actually, I think that's more of an optics issue. I mean, I've struggled with that. And as I've looked at the numbers, there just aren't enough of those people at risk. There's only 6,000 people in the denominator at risk. And you have a screening test that has a number needed to screen to save one life of 300 to 400. If you do the math, you know, that's not going to be a good measure because we just don't have enough.
Right.
On the other hand, there are measures where we have 100,000 people, and so it's those that are.
Yeah, I picked that one
Yeah.
just because of that age disparity.
Yeah,
issue
and no,
that we-
I'm really bothered by it for those same reasons, but as I've tried to look at it more, it's very challenging from a math point of view to justify keeping it in the incentive measures. What we've done.
Kirsten, did you have another question?
I did, going back just a little bit to the EHRs and Carla or staff, like, can you just paint a picture for me or understanding like what portion of the market does not have EHRs and is able to, or one of these 40 options or something? Like, how does that pencil out in terms of without nailing it and plugging in but struggling?
I don't think it's that a lot of places don't have EHRs. I think that there's a high penetration, but there's different levels of EHRs, and so in some EHRs this is built in. Like for example, the weight assessment nutrition, that tends to be built in most EHRs, but there's other things that are not, which means that you have to figure out a way to connect it and then be able to get that data to the CCO. And so that sometimes means contracting with an outside agency to help make those connections. And so it really becomes very complicated, and some of the smaller clinics who are using EHRs that don't have all the whistles and bells are not necessarily reporting in on this.
And I would add that I think the nuance to that is that even for those EHRs for which you have these standard measures that are built in, when we think about the balance between new and innovative measures versus these standard metrics, even though, you know, big whiz-bang systems, if it's a measure that we're building in Oregon, everybody has to go in and manually pull that information. No EHR has it built in, so it's a balancing act.
And the EHRs, are that static?
Yes.
Yes.
Yeah, and there's, I'll get, don't hold me to these numbers, but I'll give you some rough estimates.
Great.
So at least 75% of the providers are on electronic health records, because that's when we retired the electronic health record measure. So it's probably something higher than that. And folks know that Epic is by far the largest. But I think the last data I saw was it's still only about half the providers are on Epic, and the other half are spread over another 39 different EHR systems. And so some of those are pretty homegrown, or they might be only one of a couple of providers in the state that are using that particular system. So then when we need to go build something that's going to query the electronic health record and pull it out, they have to literally go hire a consultant to come in and build that mechanism to do that.
And even with Epic, there's like Epic Whiz-Bang, and there's Epic Lite. Yes.
If you've seen one epic version, you've seen one.
Not very epic.
No.
Well, that's the problem, they are tailored. That's why if you see one, you've seen one. They all have little bells and whistles that are for a particular place. And as Carla knows from some work we did, sometimes you make what you think is an innocuous change that even the company says, oh, we got this, and all hell breaks loose because they don't have it. And you get something else
You turn off the
happening.
button real fast.
Yeah.
We had a whole session with the metrics and scoring committee, I think about a year and a half ago, all about EHRs and EHR measures, because it is very complicated.
I'll have to go back and watch it.
I wanted to go back to the disaggregated data question. I think I understand the complexity of incentivizing metrics based on disaggregated data by race, although I'm still frustrated by it, but that's a longer conversation. But we also used to get, there was disaggregated data per metric published in the larger book. Is that information still being published? Did you move away from that because of the rate of identifiable data per members, and what's the plan for that moving forward?
I'll speak to that. We made the decision to stop publishing the data because it's too highly at risk to be significantly inaccurate with the refusal rate as high as it is. And so we need to be able to try to fix that refusal rate if that's the data source, to be able to get to something where we're much closer to being able to assure people that the data we're reporting is statistically sound.
And is the current, is there not a current plan then for publishing data at a future point in time? Or is there a plan for it, and if so, like what's the threshold we're looking for in order to be in a position to do that?
I don't know what the threshold is. The step that we've taken right now is in the eligibility system. Previous to September, you would an enrollee would come to a choice where they could say, do you want to skip the whole race, ethnicity, demographic issue, and they could skip the whole thing. We've taken away that capability. And so now there are a set of questions, and they have to answer those questions, and one of the choices by federal law is that they can decline to provide that information, but they have to go do it item by item. We're hopeful that not skipping the whole thing will cause the refusal rate to drop. Don't have any real basis to be able to guess how much of a drop that is. Then the next step that we're going to take will have to do with when we roll out the integrated eligibility system, and the whole process changes its nature in terms of how we're doing this work, and we'll be able to focus on staff training of the staff who are working with people to hopefully through that process again try to increase or decrease the refusal rate. If we've come up with a threshold number that would improve the soundness of the data, I don't know what that is, but we will need to do that at some point as we work through those two bodies of work. But we're about a year away from the full rollout of the integrated eligibility system, and so we can't do much before that at the soonest. It's a terrible answer.
It's a long time.
The one place where we did report it is, and it's only one of these measures, but it's a broader set on some of the non-incentivized measures, was that those that had, the data source was the CAP survey. We had a higher answer rate and a higher level of confidence with those. So it's only one of these incentive measures, but it was and States Valley might know, it was a higher number of the measures that we still measure, we don't have a financial incentive attached to them. So we're looking at, I think it's an example of trying to find creative ways of other data sources that we can use to try to back into to some reporting, at least where we can in the meantime.
Yeah, and I think they have problems there too, but we can talk about that later. I don't think the vendors gave me a good sample for you.
Any more questions on this slide? So the next few slides are what we view as good news stories, and looking at performance on some of the measures since they've been incentivized, as well as from 2017 to 2018. So both of these measures are as of 2019, current incentive measures. So there's one measure looking at assessments, health assessments for kids who are in foster care. And for this measure, since it's been included in the program since the beginning of the program, and there's been an over 200% increase in kids getting timely health assessments. When we started with this measure way back in 2014, it was at 27.9% of kids who entered foster care were getting both physical health assessments and mental health assessments within 60 days. As of 2018, that increased to 86.8%, and that also now, as of 2018, that includes oral health assessments as well. So we think that's further in from the program. On the right-hand side, this looks at dental sealants for kids who are ages 6 to 14, and we have seen a 34% increase in this measure since it was first incentivized in 2015. The Metrics and Scoring Committee did make the decision to retire this measure for 2020. However, they added in a measure for the same age group on preventive dental visits. So it counts sealants, but it also looks at some other oral health care that kids receive. And this is really important in that the most recent data I could find were from 2016, and it showed that Oregon is in the bottom quintile of kids on Medicaid accessing dental care. So pretty important. Next slide. So depression screening and follow-up. Since this has been incentivized, we have seen the rate of depression screening and follow-up has doubled. And then on the right-hand side, emergency department utilization for members with mental illness. This was a new incentive measure beginning in 2018, and you can see here that there was a slight decrease. Our interpretation of emergency department utilization is that lower is better, so we see this decrease as positive. This measure was included in the incentive program by the Metrics and Scoring Committee because they were, as Valerie had talked about, they were looking at trying to have measures around health equity. They had looked at trying to have measures around race and ethnicity, and where they landed due to data issues and also conversations that Valerie mentioned around the differences in demographic groups across the CCOs was trying to address this disparity for members with mental illness who have much lower life expectancy, et cetera. And while you can see here it's only a slight decline from 2017 to 2018, we also track this measure for the general Medicaid population, and this decrease was greater for members with mental illness than those without mental illness. So we saw that as a positive of this being the incentive program.
And this is really incredible performance improvement. I mean, the rates of improvement with some of these and the levels they're getting to, I mean, believe me, these are stunning.
So the next slides are measures to watch, and I'll talk about why for these particular measures. So on the left-hand side of this slide, you can see follow-up after hospitalization for mental illness. And this was included in the incentive program from the beginning of the program, though it was retired from the incentive program beginning in 2018. And you can see here, the reason why we're highlighting it as a measure to watch is from 2017 to 2018, that's a 6 percentage point drop in the rate. So that's something that we definitely want to monitor to see if that's a true drop in performance or if there are other things going on with data, et cetera.
How did you track that measure? Is that, like, how do you know?
It's a claims-based measure.
Okay. So one of the things I've always, it's interesting to me about quality measures is how sometimes the work's being done but not captured. So when you look at this, are you going back to see, are they just not bothering to code for this now, or?
When I say that whether it's a data issue, that's one of the things.
Okay.
That's one of the things. And then if you look on the right-hand side, so thinking about diabetes care, HbA1c core control, lower on this is actually better. So we're moving in the correct direction. That's great, but this is looking statewide. If you actually look by CCO, during this time period from 2017 to 2018, 9 of the 15 CCOs in operation at that time, performance actually went in the wrong direction. So though as a state, we're doing really well, we need to look at how we're doing across the CCOs. more measures to watch. So effective contraceptive use, this was first incentivized in 2015, and you can see that rates have steadily increased over the years, including from 2017 to 2018. But this is one, again, that if you look as a state, we're improving, but if you look across the CCOs, there were 8 of the 15 CCOs where performance actually declined from 2017 to 2018. And the other thing to note is that this was a measure that was retired, the committee retired for 2020. So something for us to watch. And then on the right-hand side, there is timeliness of prenatal care. This was included in the program since its inception. It was actually retired for 2019. You don't see the data point here, but it was retired for 2019 in favor of timeliness of postpartum care, for which the committee felt that there was more room for improvement. But given that you can see that we've kind of had this close to plateau from 16 to 18, and given the retirement, it'll certainly be something that we want to see what happens to the rates as it's no longer incentivized.
120%? I have to ask, 120%? How do you get 120%?
Did I say 120%?
No,
No, the chart does.
It's just the default.
Oh, it's just this, yeah. We should take it off.
We go back in time.
We would like to see.
We would like to see.
Overachievers.
Amazing, not realistic. And then, so this is initiation engagement of drug and alcohol treatment. And unfortunately, you can't, I'm not very good at colors, you can't see there are 2 different colors here. So this looks at members who are diagnosed with a substance use disorder. And the top line that you see there, that's the rate of members, once they're diagnosed with a substance use disorder, do they initiate treatment within 2 weeks? And the bottom line there, that looks at, okay, so they've been diagnosed with a substance use disorder, they have initiated treatment, and did they continue treatment for a month after? And you can see there that, you know, we had this improvement from 11 through 14, and then there was this drop in both of those. And then it's slightly improved. This is very salient given the opioid epidemic nationally and in our state, and this is a measure that, though we have been tracking it for many years, and it was our state quality measure, where Valerie was mentioning it's something that's in our Medicaid waiver, it was not included in the incentive program. However, it has been added to the incentive program for 2020, so it'll be something to watch to see if that increase continues, and if the rate of the increase, increases. Can I say that? So that's kind of where we were. And then the other thing we wanted to talk to you about are some of the developmental measures that the Metrics and Scoring Committee has sponsored. And so I think I mentioned this earlier too. You know, there's the benefit of nationally endorsed measures is, though given Dr. McKelvey's caveats about EHR-based measures, they can be calculated in a standard way. There tends to be less administrative burden, both for CCOs as well as providers. We have national data that we can use to see how we're doing, but those can be stifling in terms of innovation. So one of the things the committee has been trying to balance is, and having conversations about is, you know, new and innovative measures versus these standard metrics, and how do you balance that? And I know you've been talking about that yourselves and given some direction to the Health Plan Quality Metrics Committee. So given that the Metrics and Scoring Committee has had a history of wanting to innovate and push health systems transformation, they have sponsored 3 developmental measures. And the first is around the health aspects of kindergarten readiness, and this was a partnership where OHA has been working with Children's Institute, and we've had some technical expertise from the Oregon Pediatric Improvement Partnership. There was a work group that was brought together that created a measurement strategy in looking at what the health sector can do to get kids ready for kindergarten. There's no one measure that you can create that's going to get at that. So this work group proposed a 4-part strategy that was endorsed both by the Metrics and Scoring Committee as well as the Health Plan Quality Metrics Committee. And the first part of that is the adoption of 2 measures for 2020, one on well-child visits for kids ages 3 to 6, and one on preventive dental visits for kids ages 1 to 5. And the Metrics and Scoring Committee included those, so those will be new measures beginning in 2020. And then there is additional developmental work for the second the second and third and fourth parts of the strategy around children's social and emotional health. We're looking to develop a measure around what CCOs can do in that area. That's something that the work group, which I participated on, we heard from early learning, and that decide, you know, please do something around social and emotional health, and we also heard from our healthcare partners. And then the other developmental piece is looking at there is a current developmental screening metric, though I will note that that measure was retired for 2020. We will continue to track it, but it was retired. There is a measure on developmental screening, but it stops at the screening. So if you screen a child and they need follow-up, it doesn't track that. So what this group, and it's the Oregon Pediatric Improvement Partnership that is taking the lead, is developing a measure around capturing the follow-up. And so the idea is once that is developed, that it could make it onto the Health and Quality Metrics Committee menu, and then the Metrics and Scoring Committee could choose to incentivize. There's also developmental work around evidence-based obesity measures. There's a dearth of evidence-based, standard evidence-based obesity metrics. So this is looking at, it's in two parts. The first is looking at kind of multi-sector interventions, what CCOs can do out in the community to address obesity. And then the second part of it is looking more at outcomes and changes in BMI or obesity rates. And then the final on this slide that is being sponsored by the Metrics and Scoring Committee is a measure around the social determinants of health and really looking at individual health-related social needs and screening. For that, we will be having a work group that will start to meet in the early part of 2020, and some of the things they're going to have to grapple with are, well, does the CCO screen, or do you screen at the clinic, or do you count both? So lots of work to happen there. And then on this next slide, this was, as I know you all, this was included in your letter to the Health and Quality Metrics Committee, the health equity measure on meaningful access to healthcare services and language access and interpreter services. This was not sponsored by the Metrics and Scoring Committee. It doesn't mean they weren't interested in an equity measure. As Valerie mentioned, they did a year of work in this area, and actually including the chair of the Metrics and Scoring Committee was included in the work group that was working on this metric. So as that progresses, and if we move to the next slide, you can see this is the timeline for when each of those measures, the earliest year at which they would be available for the Metrics and Scoring Committee, if it would so choose to include them in the incentive program. And then in just thinking through the structure, they go through, we'll need to get on the Health and Quality Metrics Committee menu, and then the Metrics and Scoring Committee could choose to incentivize them. Any questions on the developmental measures? I feel like I was talking very fast.
It's okay. There's a lot.
I have a comment when you're done. You're finished. Wait. This is great work. Great work. It's really nice to see the measures, the set of measures work to move the needle. And I have nothing but compliments. I also have a dream, and that dream is that we're charged to improving the health not only of CCO members but all Oregonians. And a lot of the measures, a lot of things that influence health are outside the healthcare delivery system. What is the level of discussion appetites for the metrics committees to develop a measure that's not collected within the healthcare delivery system, such as suicide by geography, overdose rate by geography, or other metrics? And I think there's progress, really important progress, CCO 2.0, by charging CCOs to work with community advisory councils, community health assessment, that will include public health and include a representative group of the community they serve. So we're moving in that direction, but will there be a day where we could have a metric that is population-based and not measured within the healthcare delivery system?
If I could comment, this has come up in some of the meetings I've been at around immunizations.
Yeah.
When would it be appropriate to go to surveys that the health department does? The problem, I think, is in the incentive model, that's going to be very difficult.
I understand. Yeah.
Because when there's multiple CCOs in a community, which there now is more of than there used to be, the survey's by county. And so you have to divvy up those members, among the CCOs. It's going to be very difficult to make that work. And I think, David, the challenge is, I think you've got an incredible process going on here for your priorities. But there's a variety of other things that could be done. But you don't have to keep doing them through this. There are other ways to do them. You have to be more patient, or you have to take some risks to get things done. But there's, I think, some other ways to get results that are good, maybe not as great as these. And to me, that's the big question. When does the state start to try and get some mileage out of measures that have either gone through this process and now no longer are, or haven't gone through this process and probably aren't going to? But there's interesting stuff that could happen.
If I could comment on that, this is going to come up a little bit when we kick off our agency strategic planning process. One of the things that the group who's going to be working on this are going to see is a video from Oklahoma City, where they went through a strategic planning process, and their big long-term goal was for Oklahoma City to lose 1 million pounds. And the idea, the data said that they were one of the most overweight cities, if not the most overweight city in the country. And the idea was not, oriented around, sort of narrowly around diet and exercise. It was oriented toward what are our investments as a community in free recreation. Where do we build sidewalks and walkability and bikeability and those kinds of things, so it had a land use element to it. It was an organizing principle around which a whole bunch of things that a city in the ordinary course does, but they weren't thinking about it in terms of the contribution to health. Not thinking of that as the, kind of a metric that we would pick. But remember, to John's point, part of the vision of CCOs is that they're not just sitting there in the healthcare space. They lie at the intersection of education, community, all these kinds of things. We're requiring them to align their plans with public health, with local hospitals. And I think in that alignment, and that work across sectors, incentives, even if the incentive ultimately is paid to the CCO, I think can drive those kinds of population sorts of changes in the system. And in fact, that the whole idea is that they have to, because you can't make progress on the triple aim solely with the 10% of what happens in healthcare interactions. We keep saying that. We actually now need to start pushing the CCO model to act on that.
I was just going to say, I think the group has like another slide or two, and there's some discussion.
What's there?
It's just a discussion. It's just a discussion question.
And Jeff asked me to facilitate this part of the discussion. So looking at those questions, do members of the board have some questions they have first consistent with those, and then any others?
I do. I have a question, and I think it might be best suited to flip to the next slide, which shows the diagram, or maybe the next one, or maybe not.
Oh, I think it's a separate handout.
Yeah. So this handout in particular, where we've got the health plan, quality metrics, community metrics and scoring in this board, and I think learning from what we experienced with the health disparity measure, where there was disagreement or misalignment between the groups, between the board, between the committee, and between metrics and scoring. I wonder if you can help illustrate for us what we've learned about that mishap. If that's not placing blame, it's just recognizing systems weren't really coordinated in terms of communication and intention. What we've learned and how we've remedied that kind of notion, preventing that from happening again.
So one of the things, so you saw the slide where we had the developmental measures, and there were those that were created at the behest of the Metrics and Scoring Committee, and I think with those, I think our lessons learned are around pacing, and given that the Health Plan Quality Metrics Committee and the legislation, it says that they should listen to recommendations from Metrics and Scoring. So I think it's including metrics and scoring earlier. So for example, with the equity measure there, that group is presenting and giving an update to the Metrics and Scoring Committee on next Friday, actually. And then the Metrics and Scoring Committee will hear from them again before kind of making a pitch would be made to the Health Plan Quality Metrics Committee. So I think including the Metrics and Scoring Committee and in our timing and allowing the space for the Metrics and Scoring Committee to to move forward and make recommendations, I think is helpful. That's, I mean, some of the learning that we have had is around the pacing and where things are presented first.
Do we think we've given adequate direction around authority and decision-making and recommendations? Do you know if we are confused in that as well?
If I might, I think one of the challenges is, this is a deliberative body. That, it's consensus. I mean, almost everything that we eventually do is unanimous, and that takes a lot of deliberation, information, et cetera. Metrics and scoring is action. They vote. While oftentimes it's unanimous or close to it, they have a lot of close calls. So does health plan quality metrics. And the ethics vote that day was 5-4. I think the 5 included some really sophisticated technical people who are doing great work for us in other respects, but just were not satisfied that their technical concerns, the numerators and denominators, had not been defined. And for whatever reason, that didn't come out until that final discussion. And then I think there was some concerns among some of the CCO members of that group that this just hadn't been well enough defined for them, and equity hadn't been well enough defined. So, one of the things we've talked a bit about is that it might be good for the leadership of this group and the leadership of HPQMC and the leadership of metrics and scoring to get together on some kind of regular basis and talk about that. I mean, I might say, I'm very impressed. I mean, OHA leadership has been very involved. The staff is incredible. The leadership of metrics and scoring is incredible, and so is the case for HPQMC. John Collins, now in a different part of OHA, is now the co-chair of HPQMC. And you'll hear from Will, but I just recognize Will. I mean, this guy has worked how many years? 4 years? 4.5. Yeah. From Medford, coming up, for multiple meetings on the phone. He's a CCO guy, but he still does great work. I'm just kidding, because I naturally have some suspicion about industry and
The two of you are wearing the same shirt, I think.
yeah. But I think that authority thing could work. Because I know as liaison, I can't bring up anything, and Christian Tarani, who does HPQMC, you can't bring anything up there without these people weighing in with what they think. I mean, our letter is still being discussed there, and they still have concerns and suggestions. All I can really do is say, well, I'll bring it back here. I don't have any authority, and I don't want it, But, so those sorts of issues could be sorted out better.
Zeke.
Guess I've been on the whole time. Sorry, Jeff. I think somewhat to Brenda's question, it's still a bit unclear whether the letter actually has had any impact or not. So to this question of the relationship between the policy board, the quality metrics committee, and the metrics and scoring committee, it's probably right that they're framed as this kind of like on a plane together, and then there's this loop back between metrics, quality metrics and metrics and scoring, and that the policy board kind of comes at it from a side. And some of that I think is a function of the fact that we've only had this type of relationship for a couple of years, but I just appreciated the question, Brenda, and I'm not sure that we really actually deliberated on the question much about how the lines of authorization and engagement are kind of productively moved as we move forward. So I'm not totally clear on how the letter has really had an effect. But I actually had a different question. So I wanted to go back to the presentation as a whole, and I was thinking about how one might make sense of the incentive metrics process by saying what gets measured gets done, or what gets paid for and gets measured gets done. Someone else might actually say what is easiest to get done has been measured and paid for in the process, and it'd be hard to kind of discern between those two perspectives. I think that the report from John Connolly said a little bit of both. Both said like what gets measured gets done, and said, and as you move forward, you might want to think about moving the benchmarks up higher and pushing towards kind of more clarity about the kind of disciplined improvement we want to see in this system. So I wonder from a staff perspective how you balance that tension given the reality of the makeup of the metrics and scoring committee, and how you think about where we want to land on that as we move forward, given also this reality of the relationship that we kind of focused on quality here, but clearly heard also that there is a relationship between quality and cost as the overall pool is affected by overall cost increases as well. Is that a fair question? Actually, don't answer that part, just what response do you have to the question?
Okay, so my role is kind of an interesting one because I balance the staffing the committee and making sure that they have the information that they need to make the really important decisions that they have to make, as well as there are times when I wear my agency hat, and we as an agency do make recommendations to the metrics and scoring committee, both in terms of we came out with recommendations for 2020 for measures that the committee had made it very clear that they were going to reduce the number of measures in the set. And so we came out with a set of recommendations in terms of measures that we felt, if you're going to reduce the set, at least at a minimum include these, and we actually recommended that they include more than just those that we had called out. And I think we also give recommendations in terms of the benchmarks that are set, bearing in mind what we learned from the waiver report, and also looking at, it's kind of straddling that line of technically supporting the committee because we have information to look at performance in Oregon compared to how we're doing nationally. We can make some educated recommendations about that in terms of when they might want to increase from say the 75th to the 90th percentile, or if we're doing well in Medicaid, at times considering when they might want to shift to looking at a commercial percentile. I will say in looking at many of the benchmarks to 2020, I'm going to pull that out as an odd year, but many of the benchmarks for the program are at the 90th percentile for Medicaid. So I do think there is room for some discussions about what's the bar beyond that. And one of the things that they have in their retirement checklist is if something gets to the Medicaid 90th percentile, is that a point when you should actually retire it and put something else into the program. So all of that to say, I think that, I'm looking at Jeremy and Stacy, I think that in terms of the recommendations that we as an agency have made to them, for us, we see this as a very important program and have pushed for high standards, I think.
I think as a clinician, with the quality measures, that they're driven by process. So you have to capture the data, whether that's through the EHR claims, and all of that involves looking at workflows and looking at how people not only do the work but capture the work. And as I think John has alluded to, that is really difficult to make changes within a clinical system. And so the fact that we have accomplished as much as we have, I think is really something. It was really interesting. I was at a meeting and there was a discussion about how you can spell dietitian 2 different ways. And somebody asked, well, so what is the recommended spelling? And so they said what it was, and yet we still hold on to the old spelling, and it's been over 100 years. And so in over 100 years, we still haven't made the change in how we spell dietitian. And so the fact that we've done as much work as we have done within such a short period of time is really incredible from from the clinical perspective. So I think while the system that we might have has areas of improvement, it has been quite successful. And so, you know, and that's thanks to the work that the committee members have done as well as the staff members. So I'm glad that we're focusing on areas of improvement, but I think it's really important for us to understand how amazing the accomplishments are that have been done within a system that takes sometimes over 100 years to make a change in the spelling.
I'm struggling so hard right now not to Google dietitian. Fact check that.
Well, what's sad is I can't remember which one's the correct spelling.
Why hasn't changed?
You know, I might say that there's a gold mine of information away from the incentivized measures. There's 17 CAHPS measures, 17.
Yeah.
And, you know, I realize from an incentive point of view, they're not very good because you can't give the CCOs, here's how you're doing every quarter, because the survey's done once a year. But it's good social science. And actually, if you look at how Oregon Medicaid is doing within those CAHPS measures, I got a little spreadsheet. One of the problems is there's a lot of 90% performance, especially on children. I mean, the CAHPS results for children are extraordinary. And even some of the others, I was trying to look at, you know, the 90th percentile and even best performance out in Medicaid for HEDIS CAHPS, which is similar. So there's some great stuff going on there. I think there's still some tweaking needed around race and ethnicity. When you look at the samples that they're getting, there's something either I'm not understanding or is going wrong there. I mean, I was surprised as I was going through there. There's a measure on readmissions, hospital readmissions, and 13 of the 15 CCOs were worse in 2018, and significantly worse. And given that hospitalizations are why this program is succeeding in terms of cost, I wonder, is that a warning sign? This ER stuff is still fine. Outpatient ambulatory is actually up a little bit, which you would expect. But and I know readmissions are weird. They've been much more difficult, but you know, I think there's some interesting information in there. And one question is, what role do we play in the non-incentivized performance information when it's either really good or not so good? You know, because sometimes I was, you know, in my little spreadsheet, the Pacific Source Gorge, they do really well on CAHPS, really well. They're doing something to improve their CAHPS performance, and others not so. So there's I mean, for a performance measurement person, there's just a gold mine of information here. It just depends on how much you want to use it.
This discussion makes me wonder if you all have any interest in our walking you through a presentation of the outcome measures we use at the agency level to track and manage our performance. We kind of blew by it when we showed you the performance system months ago, but after this discussion, it might be worth a bit of time on the agenda for us to show you that. I'm seeing head nods.
I also wonder about the fee-for-service population. I think one time, isn't the fee-for-service population the third biggest CCO or something?
That's about right, yeah.
Yeah. So there's a big population of people getting taken care of outside of the CCOs, and I bet that's not a very pretty picture.
I think we run the third largest and one of the worst CCOs, actually,
Yeah.
when you think about the fee-for-service.
Yeah, because I think you'd also see what a difference these organizations can make.
Yep.
So, any other thoughts or comments about these questions? Rosalind?
Yes, thank you. I just wanted to comment on this developmental measure timeline on the social determinants of health. And it says possibly ready by 2022. And I'm not quite understanding now. So these years, 21, 22, and 23, and so these measures are going to be in the future. They're something that you folks are pulling together and how you're going to work with it.
Yeah, so we're looking to create a measure that the Health Plan Quality Metrics Committee could then include on the menu of measures from which the Metrics and Scoring Committee chooses incentive measures for CCOs. And so the first year, that 2022 is very aspirational, and it is much more likely that it will be 2023, where we would have something that has, you know, clear definition of how we're going to calculate it, that we have been able to work with clinics and CCOs in terms of testing and make sure that we can actually get the data. So then 2023 would be the first year when Metrics and Scoring could say, okay, we have this measure, we want to include it in the incentive program.
Okay. Is there a committee that works with social determinants of health currently with the Health Policy Board? Or is it just overall?
So what do you mean?
Well, I mean, this group is going to create these, but is there assistance from collaboration from anyone else, or?
So my impression is the committee pulls in resources, correct?
Yeah, so to create this measure, in the beginning of 2020, we will stand up a public-facing work group that will work on the measure. Yeah. And I can work with Jeff so that you all are aware of when we're seeking folks to be on that.
But like your children's group has been that for the children's developmental measures, and that's incredible stuff going on in that group.
Oscar?
Yeah, so my other question would be then, is the timing of this, so does that mean that the obesity measure has been worked on, has already been worked on for a while, and that's why it's coming up earlier? So are we looking at a 3-year timeline when we want to create a new measure?
It depends on the measure, but first question, yes, the obesity measure has been in development for some time, and that's why it would be ready earlier than, say, the social determinants of health measure. I don't want to say hard and fast that it's a 3-year timeline. I mean, for a lot of the national standardized measures, you're looking at 10 years and $1 million to get things ready, and we don't have $1 million to do these things. 14 years. It depends also on the type of measure. So for example, if for the social determinants of health measure, this group decides you have to do something that's going to come out of an EHR, to Dr. McKinley's points, we need to work with some clinics and CCOs to test and see if we can even get it out. So it really depends on what the measure is. But generally, 3 years would actually be very quick to develop a metric.
Sarah, talking about testing also. Testing and measuring.
And that time also has to include, we'll break the chair of Metrics and Scoring is saying to note for you all about testing of the measure. So that includes working with CCOs who will work with clinics to get some test data to try and validate, et cetera. And again, 3 years is fast to do that.
So believe it or not, we're at the end of our time. So thank you very much. Greatly appreciate it.
Thank you.
Chris DeMars will be joining us now.
Okay. It says it's on. I saw people pressing.
So should be a screen.
Okay.
So hi everyone, my name is Chris DeMars. I'm the director of the Transformation Center. And today I'm going to be providing an overview of value-based payment under CCO 2.0. I've been here before talking about a lot of this, so this will be kind of a refresher. Also, just making sure you all know where we landed with regard to the requirements. I'll also be talking about multi-payer alignment with regard to value-based payment and some of the resources and technical assistance that will be provided by the Transformation Center for the work under 2.0. So just to ground us all in the definition of value-based payments, they're payments to providers that reward value instead of volume of care delivered, rewarding providers for a combination of high-quality care, positive member outcomes, and cost savings. Really, the goal of increased use of value-based payments is to incentivize delivery system reform, and all value-based payments must have a link to quality. So driving forces behind the increased use of value-based payments back in 2011 when House Bill 3650 was passed that created CCOs. There was also language in that legislation that stated that OHA needed to have a role in supporting the increased use of value-based payments. Moving forward more recently, in 2017, Oregon's renewed 1115 waiver included language that says OHA needed to work with CCOs and network providers on a plan around a set target of value-based payments to be achieved by the end of the waiver period in June of 2022. And then, as you all know, value-based payments were identified by Governor Brown as one of the 4 priority areas for CCO 2.0. With regard to CCO's performance on value-based payments over the first contract, CCO 1.0, what we found in looking at their use of VBPs is that the use of value-based payments really varied by CCOs. CCOs had more experience with non-fee-for-service payments, so capitation, but the link to quality was often not there. Also, a one-size-fits-all value-based payment approach doesn't work because of differences at the CCO level in geography, plan size, and provider market power. And then we also realized that our current reporting mechanisms were not adequate to track value-based payments. So you'll all be talking about sort of changes we've put in place with regard to that as well. So as you all are very aware, through CCO 2.0 there has been a robust public engagement process, and in addition to all the different avenues that have been kind of managed around CCO 2.0 broadly for the 4 areas around the 4 priority areas with regard to value-based payment, OHA also convened an OHA CCO VBP work group and conducted a specific survey for providers. In general, we heard that to a large degree there was support for increased use of value-based payments. The 3 kind of most important, or I guess highlighted pieces of feedback we received are on this slide, and so I'll be going over those pieces of feedback and then the resolution that we've put in place. So number 1, we heard a request that value-based payments that there not be a prescriptive approach, that there be allowances for flexibility at the CCO level to make sure that CCOs can implement the value-based payments that work best for their populations and their locations. And as you'll be hearing later in this presentation, that we have done that. We have designed the requirements to allow for that flexibility. Number 2, we heard from a number of different sources feedback that they're kind of concerned about the potential of value-based payment models to to have unintended consequences and exacerbating disparities for populations at risk of disparities or those with complex care needs. An example of that is a provider that might the access would be compromised, providers not kind of dropping or firing is the term, patients that are more difficult to manage, I'm putting that in quotes, because the care might be more expensive. So that is a risk that has been highlighted nationally. And so the approach to that we put in place now is that there will be conducting interviews with the CCOs every year about their strategies to try to minimize disparities. Exacerbation, for example, if tracking providers kind of their patient numbers and making sure that they're not dropping patients, not firing patients. Another strategy, and this is a little longer term because there's a lot of work that needs to be done in this area, is risk adjusting. The CCO to provider contracts risk adjusting based on social factors, not just medical factors, and we're going to be looking at ways to help CCOs do that. The third was a request around alignment for metrics, especially in areas where there's more than one CCO in overlapping service areas. And so there is a requirement in the contract, the 2020 contract, that CCOs in areas with overlapping regions where they're implementing the same type of value-based payment, and I'll be getting into these in a few slides, called care delivery area, BBPs, use similar metrics, and OHA will be convening CCOs on these conversations.
How, with the first two resolutions, how do you do that if we don't actually know what 42% of the members' racial demographics are?
That is a good question. With the first one, so that is just around flexibility of value-based payments. So I would say that isn't so tied. It's more the second one. Is that? I just want to make sure I understand.
But the first one, like, I understand the flexibility.
Meeting
But there's also
needs.
there's some amount of accountability at CCO level as well that's required to ensure that they're actually flexibly serving populations effectively, right? So there's some relationship between our understanding of who they're serving in what ways with those value-based payments and the dissonance of not actually having member-level data of the populations, right?
I think that's a great point. I would just say that the kind of strategies that I heard at the previous presentation to get better data will inform that. So, good point. All right. This is a very busy slide. I think you all have seen this before, and you don't have to be able to read the words there. But what this is a framework for categorizing value-based payments. And you see that acronym APM, that stands for Alternative Payment Models. Just noting that OHA and many other entities across the country are moving from alternative payment models to value-based payment to highlight that link with quality. The Healthcare Payment Learning and Action Network is a public-private partnership that is supported by CMS to really accelerate the use of value-based payments across the country. The LAND framework has been kind of the nationally adopted framework, and OHA will be using this framework in terms of our tracking the value-based payment progress under CCO 2.0. The categories, the left-hand category, that's fee-for-service, so that's not a value-based payment. The other two, categories 2, 3, and 4, have different value-based payment models, and they progressively become more advanced. And I'll be giving an example for a model in each of those categories in the next slides. So first, category 2, the LAND category 2, is basically, it is still based in fee-for-service, but there is a direct link to quality and value. So category 2C, there are 3 categories, 2A, B, and C. 2C is the one I'm going to talk about the most here because it's very important for our CCO 2.0 requirements. These are payments that are still a fee-for-services at the foundation, but they're coupled with incentives or disincentives for providers that achieve or fail to achieve quality improvement targets. And so the incentives can be in the form of a bonus payment to a provider or a percentage increase or reduction in rates the following year. And you can kind of think about the incentive metric program. That's the way CCO pays, OHA pays CCOs. It kind of works as a pay-for-performance program. I have an example on each of these 3 slides. This example here is a primary care provider that is delivering certain substance use disorder treatments. They may be paid for performance on certain metrics that are on this slide. So the next is category 3. This is more advanced than category 2. And category 3s, they're still built on fee-for-service, but they're considered more advanced because they use potentially more powerful incentives for well-coordinated care, for a comprehensive set of services in a single episode, or a patient's total cost of care. So specifically category 3B, that means that providers are eligible to either share, so they get a kind of a lump sum of money, like kind of think about it like a capitated payment for that provider, and they have an opportunity to either share in the savings, or they may also be at financial risk if they don't manage the care within that amount of money. And then there are also quality metrics that are tied to that payment as well. An example is a maternity bundled payment episode. So it's an episode payment that would entail the care from prenatal to postpartum care for both the mother and the infant, and then some kind of more unpredictable high-risk costs such as neonatal intensive care unit stays might not be included in the episode. And then finally, category 4, these are population-based payments that have no link to fee-for-service. And so kind of ideally, that's the hope in the longer term. And these are considered most advanced. And so category 4A, these are prospectively paid value-based payments that cover a certain condition or all the care delivered by a particular type of clinician. So the care could include a medical home model for a patient with a specific condition like cancer, and it wouldn't just be for the chemotherapy, the entire condition, all the care, or primary or specialty care delivered to a whole population. And then there's an example there about a primary care provider receiving the capitated payment for all their primary care services for their attributed members, and then also has quality metrics associated as well. So that's kind of the value-based payment 101 in a nutshell. Now I'm going to move to the requirements for CCOs under CCO 2.0. There are 3 distinct requirements that work together as a package to support the AAA. So I'll be going over each of those individually. So the first requirement is that CCOs are required to pay a per member per month payment to all of their patient-centered primary care home clinics. And this is beyond the fee-for-service payments that they provide. This is actually land category 2A, and the name of it is foundational payments for infrastructure and operations. Basically, these PMPM payments enhance the infrastructure for the PCPCH model, for a model that we know works, and you see evaluation findings on the bottom of this slide. The payments will allow for advancement and sustainability of the model and support staff and other services that aren't otherwise covered through fee-for-service. And so an example might be a clinic that wants to bring on a social worker or a case manager or someone a staff member who wouldn't be supported through fee-for-service. So that's requirement number 1. Number 2 are what we are calling care delivery areas. And so just stepping back, when you think about value-based payment, I think about it as it can be have an end in itself in terms of making sure that quality is maintained and cost is managed. But value-based payments can also be used as a lever to advance specific policy goals. And so these care delivery area VBPs were put in place to take advantage of this second lever. CCOs will be required to develop value-based payments in each of 5 care delivery areas. These are maternity care, hospital care, behavioral health care, oral health care, and children's health care. And the Health Policy Board and the governor have specific policy goals, as you know, in each of these areas, such as the Children's Health Care Priority that the Health Policy Board and the governor has. And so these need to be value-based payments in that land category 2C or higher, that pay for performance or the more advanced 3 or 4. There's no requirement with regard to the number of members in these value-based payments, the number of dollars. It's really the goal is to get CCOs experience and exposure to these 5 value-based payment kind of types, these care delivery areas. And we're imagining they could even be pilots that CCOs put in place and really want to kind of see, do they work? And OHA will be learning from all of these care delivery areas, VBPs, as well, with the potential that, say, CCO 3.0, maybe some of these care delivery VBPs would become required. But at this point, the science is not out there to be able to be more prescriptive. And as you heard me say at the beginning, we want to provide the flexibility at this point as well. With regard to implementation of the care delivery areas or requirements within the contract, so in 2020, CCOs are required to develop care delivery areas in 3 areas: hospital care, maternity care, and behavioral health care for implementation in 2021. In 2022 and 2023, CCOs need to implement one of the other 2 remaining care delivery area VBPs, so children's health or oral health value-based payments. And then the third requirement, and this kind of brings it all together as well, these are the value-based payment targets. As you may remember, there was a requirement in the request for application that CCOs say they can pay of their total global budget, 20% of that will go out the door in the form of a value-based payment in category 2C or higher, so that pay for performance category or higher, starting in January of 2020. Over the 5-year CCO 2.0 period, that percent increases until we get to 70% value-based payments in land category 2C or higher in 2024. In addition, in 2023 and 2024, there's a requirement around that land category 3B, that shared savings and shared risk, which is more advanced. The requirement is that 20% be in land category 3B in 2023 and 25% in 2024. And then this slide also shows when those care delivery area VDPs need to be implemented. With regard to, you may be wondering where CCOs are now with regard to their value-based payment kind of plans under CCO 2.0. According to the RFA responses, on average, CCOs are at 50% value-based payment, but 3 of them were not at 35% yet. So we feel pretty good about where we set the targets, and hopefully it's not too much of a push, but enough of a push to get kind of all CCOs at these percentages over the 5-year period.
Can I ask a quick question on the 2021 objectives around hospital, maternity, and behavioral health? What happens if a CCO does not meet that threshold or is not able to enact those contracts, that requirement?
That is a great question. We have yet to kind of identify the specific kind of compliance related responses to that. And so what I do know is we will be making all this information public. So at a minimum, there will be kind of a knowledge across the state that does not happen. Looks like Jeremy might want to be jumping in.
Well, I was just going to say that we built in a lot more accountability compliance mechanisms for and sort of corrective action type levers that we can pull in the next contract. The challenge that we need to work through is when we pull which of those levers and how we coordinate that as an agency, because there's lots of stuff that we're expecting CCOs to do, and we need to be able to sort of hold them accountable, but also respond accordingly in terms of the full landscape of what's required in the contract and where they're at. So we're actually in the process of standing up a new kind of quality assurance, quality improvement team and structure within the agency, and a process by which we'll be tracking not just this, but all of the things that we're expecting in the contract, and then we'll look at those collectively on a whole to figure out when a CCO is falling short, what the appropriate response would be, which sometimes might be corrective action, sometimes it might be just needing to deploy more technical assistance and collaboration with the CCO, because they might just be struggling in terms of subject matter expertise or things of that nature. So it won't be a one-size-fits-all. It will really be, I think, responding to the collective, what's going on with the CCO and why.
When you say that average is at 50% VVP, at what level?
At the 2C and higher. So basically, the average is 2C and higher. So that the requirement that's listed on this slide.
So all but 3 CCOs are already meeting the 2022 goal?
No. Sorry, I should have. I actually don't have that. All but 3 are meeting the 2021 goal. And I'm not sure about that. That 50%, when I said that was on average. So I would have to get back to you on this. Okay.
Do you happen to know the highest CCO percentage?
Do you know that?
Yeah, it's around 75%. But again, that's in the RFA proposed responses. So I think once we have data, we can see if everyone is measuring those in the same way. So we have technical guidelines for how you count your VVPs, so that we know we're all talking about it in the same way. We're meeting in the same land categories, if that makes sense. It's actually fairly complicated to group a VVP, and so we have some guidance to make sure that after this, we'll all be talking about it with the same technical specifications.
Should I repeat any of that to get it on the
Yes.
mic? Okay. So the question was, well, I think you heard the question. So the highest was 75% that a CCO said that where they are with regard to their value-based payments in category 2C or higher as of the time they submitted their RFA response. The issue with that is OHA hasn't confirmed that the way that CCO is categorizing their data meets the way we want them to categorize, because as you saw with the land framework there, it gets pretty technical, and I'll be talking about some guidance that we have put out, but we can't confirm that CCO that said they're at 75% actually is. So they might be, we'll see.
So just a time check, we
Sure.
have about 15 more minutes,
Okay.
so I'm hoping we can get through your
Yep,
slides.
Yep, I can talk fast, as you probably know, but see.
Thanks, Chris. This is probably a better question at the end, but I probably won't be here by the
Okay.
time you're done. But since you raised Jeremy, the kind of build out of a quality assurance system with the new model, this is an uneducated thought, but it occurs to me, given the last presentation and this presentation, I mean, it has felt for a while like we have put a lot of emphasis on the incentive measures as really an only way to think about quality in CCOs. It isn't the only way, I get it, but in terms of what's really been visible at this level, notwithstanding the notion of like what we pay for gets done, I do think that as we think about where values-based payment as a system and as a mechanism and a lever fits into the direction of CCOs moving forward, and what some of those other kind of accountabilities are that are built into CCO 2.0, there is an opportunity then for potentially a broader discussion about some of the things that I think that this board has really expressed some interest around, both in terms of disaggregated health outcomes by race, and in terms of population health as well. So, I mean, particularly as I think about the CDAs here, there's an opportunity to think differently about the relationship between community or population level health and what role the CCOs play in that. And I just appreciate, I think that there was a lot of flexibility built into the kind of expectations around what the CCO model can and should look like moving forward. And maybe I'm just picking up on what staff's already trying to do here, but I do think the ability to bring these conversations together and to then be intentional about our understanding of what limitations there are on certain elements of the system and where there's opportunity in other places that help to shape some of the questions that I think we keep coming back to as we're engaged in the conversation about incentive metrics, and frankly are just, it's like it's left flat because it is really only one part of the system. So I appreciate the juxtaposition of these two, and I think moving forward, I'm really interested in how this begins to play out, not just at the CCO level, but also at the provider level, because I think that's a place where there's more rich opportunity for some of the reflection on what the system looks like that we're looking for at a board.
Appreciate
It was
that,
more of
thank
a
you.
comment than a question, sorry.
All right, so this slide, once again, the busy land slide, it brings it all together though. In that, you see the top under 2, that's the category 2A, and I just want to make sure this is clear. Those PMPM payments for PCPCHs do not count for the 20 to 70% target. So those are just, CCOs need to make those payments. And then category 2C, the pay for performance, and then all of category 3 and all of category 4. Those are the different types of models that CCOs can use to meet their targets and their care delivery area VBPs. So now moving on to reporting, we have put together kind of a package of different reporting mechanisms that will comprise an annual CCO value-based payment progress report. It will include information from those annual value-based payment interviews that I mentioned earlier. We'll be asking CCOs about their value-based payment plans over the coming year, their strategies, like I said before, for minimizing the risk of exacerbating disparities. We'll be starting those in this coming June of 2020. In addition, CCOs are required to submit data to the All Payer All Claims database on their value-based payment activities, and that APAC has had to be revised in order to accommodate for this information. And what's really great about using the APAC is we'll be getting data on value-based payments not just from CCOs but from all payers in the state, so we'll be able to make some comparisons. The care delivery area value-based payments and the PCPCH VBPs, there's some supplemental reporting for that because it's not captured within the APAC. And then also all CCOs need to have sufficient health information technology to be able to give data, appropriate data to their providers, and will be kind of getting updated status on their progress and having the right IT as well. So that the annual report won't be available as of January 2022, but like I said, we'll start the data collection in mid-2020. Now, moving on to multi-payer alignment. So CCOs working in the value-based payment space and increasing their work in this area is one thing, but to have the greatest impact, we're hoping for system-wide value-based payment adoption, and OHA is using the levers that we have in order to try to advance that. So first is within OHA and OEB and PEB. The OEB and PEB boards have had conversations around and looked at the CCO 2.0 requirements and have aligned with the high-level VBP targets that the CCOs have adopted. And also in the first half of next year, 2020, they're going to be identifying sub-targets in specific land categories, especially related to those categories 3 and 4. And then in the primary care space, I think you've heard me present before about other efforts that are happening around the state around primary care, value-based payment adoption, and the CCO 2.0 requirements are all aligned with these two efforts. One is the Comprehensive Primary Care Plus program. It's a national primary care value-based payment initiative. Oregon is one of, I think, 18 regions in the country. There are 12 payers in the state participating in that. The other is the Primary Care Payment Reform Collaborative, which is focused on all payers. And just real briefly to give you an update on, and I know that you get updates on the collaborative periodically, and probably heard earlier today from Carla, but this is a collaborative that was established in 2015 through legislation that OHA convenes to develop and implement a primary care transformation initiative. There are 45 members participating, representing all different parts of the system that touches primary care, and behavioral health is also a real big component of it as well. It began meeting in 2016. Legislation has the collaborative meeting until 2027. We submitted an annual progress report to the legislature and the Health Policy Board. In 2017, there was legislation that further defined the scope of this primary care transformation initiative. It has 3 goals: to increase investment in primary care without increasing costs, align primary care reimbursement across all purchasers, and to continue to, quote, improve reimbursement methods. That's the language in the legislation that basically means moving away from fee-for-service to value-based payments. The collaborative, there was a consensus around a payment model that the collaborative has adopted in late 2018. It was codified in a report that came to this body and the legislature earlier this year. It's basically a payment model for primary care that's based on CPC Plus, but CPC Plus doesn't have all the payers or all the providers in the state. It would take that model and extend it to the entire state. There'll be much more information for you at the next report that we submit in the first quarter of 2020. And then finally, getting back to CCO 2.0, I just want to call out and Jeremy kind of alluded to this, but the technical assistance that the Transformation Center plans to provide to help the CCOs in achieving their goals. Initially, we're going to be developing technical assistance around the care delivery area, value-based payments, the maternity, hospital, and behavioral health VBPs that need to be developed in 2020. We're also looking at developing sample contracts for CCOs to use in their value-based payment arrangements, especially as they move from pay-for-performance, which CCOs have more experience with, than moving to the risk-based contracts. And then also sample contracts in those 3 care delivery area CDAs, care delivery area VBPs. And then finally, we already have some resources up for CCOs on the Transformation Center website. One is our VBP roadmap, which gives a lot more detail around the requirements that I've talked about today, and the other is what we call the technical guide, and it gives in-depth examples of what counts and what doesn't count in the different VBP areas, and this will help CCOs make sure that how they're designing their value-based payments kind of meet the categories as we are, defining them, so that they can be sure that they're on track to meet their targets. So with that, happy to answer any other questions.
I think you need to take a breath.
Take a drink of water.
So how do you know if this is successful? So how do you know that they're being paid the right rate to do this work, that the goals are being accomplished? Like, how are you going to define that? Because my assumption is that a value-based payment in one area may not be the same in another area. So at some point, are you collecting best practices? Are you saying, well, based upon this outcome, that was the right amount, that was too little, so they couldn't accomplish the goal? Like, how are you going to look at that?
So you're asking beyond how we know that they're on track for meeting the requirements that I laid out, but how do we know that the value-based payments they're putting in place are working with regard to quality and outcomes?
Because I can see the models being developed, I can see them saying we're doing this, but is it the right model? Is it the right amount? Are you getting the right results?
That's a good question. We are in the kind of scoping the evaluation piece now. I mean, beyond tracking the contractual requirements kind of versus. So we have more thinking to do on that. We may bring in an outside consultant to kind of help, with an actual evaluation on the ground, kind of looking at VBP models and seeing like the outcome on patient, outcomes and care and costs. But at this point, we don't have that fleshed out yet, and I don't know.
Well, I would add, really want to heighten the Transformation Center's role in CCO 2.0 around spreading best practices or emerging best practices, and we've done a good amount of that, but really going to take that to the next level over the next 5 years, which means we also need to engage in good dialogue and back and forth with CCOs so we can figure out what is working and try to figure out what data we might need to evaluate that and spread that. So we've been just starting to have some internal conversations around what we might need to build out, including potentially maybe outside resources that can help us do some evaluation. The piece I would also add is that when we were going through a lot of these conversations last year, you may recall even some providers coming in testifying that we really don't need to focus on value-based payment, we need to focus on other types of reforms. And it's true that for a long time there hadn't been, I think there was a national feeling that fee-for-service is broken and not going to help us get to sustainability and outcomes, but not great evidence to say exactly where is it working and how. And suddenly in the last 6 months, a bunch more has popped out. And so there's now, it feels like almost on a monthly basis, some good reports coming out. Massachusetts they just did an evaluation of 8 years of the ACO arrangement, and Massachusetts found huge savings, improved quality. We've seen some of that in California. We've seen some of that in the VA system, which is a single payer system. So we're starting to see that emerging, and we're starting to think about how were they measuring that, or things that we could do to sort of do that same type of evaluation in Oregon as we're rolling this out.
Leads me to a question around the role of the Transformation Center in supporting provider networks and their readiness to accept value-based payments. So far we've talked about it from OHA to the CCOs, and I'm curious how the delivery system is being supported and adopted.
Yeah, that is a great point, and we just started to kind of think through our technical assistance approach at that level as well, not just at the CCO level. One thing we know we're going to be putting in place is information kind of communications and just information that would be specifically for a provider audience on value-based payments, because we know that there's a wide variety with regard to providers kind of understanding even what this is. We do plan, well, we're tentatively planning, I shouldn't say we're definitely gonna do this, but I think we will put out another provider survey. So we did a provider survey during the CCO 2.0 policy development process. Put out another survey maybe at the end of this year once there's a little more traction with regard to the care delivery areas and those kind of contract things, to get providers, a sense from providers of where do they still have questions, what would be helpful for them. And I'm very open to suggestions from this body or others as well.
We've also talked about trying to develop some model contract language, not to say that people have to use exactly that language, but to try to give a little bit more concrete specificity around what do we mean by these line categories, and as much as possible help people kind of plug and play as opposed to have to reinvent the wheel over and over again.
So, Chris, I'm sorry, thank you so much, and we need to transition to our
Okay.
next set of speakers. So, thank you. So we have Will here, and then I think Amit's on the phone, is that right?
I am.
Okay, thank you for joining us by the phone. And Will, do you want to do introductions?
Absolutely. So
Thank you.
I'm Will Brake. I'm the Chief Operating Officer for All Care Health and All Care CCO. And then Amit, do you want to introduce yourself and your role?
I'm Amit Shah. I'm the Chief Medical Officer of Care Oregon and Vice Chair representing Columbia Pacific CCO and JCC on the Metrics and Scoring Committee.
And I've been the Chair of Metrics and Scoring Committee for 2.5 years and have been on the committee for 4 years. So I think I'm one of the longest standing members of Metrics and Scoring. Have enjoyed my time. Next Friday is actually my last day after 4.5 years, and I've enjoyed every minute of it. It's been fun to watch the evolution of the metrics and on the different committees that we've had come and go from the committee, because during that time we've had just about 100% turnover in the committee, and the staff actually also. And I wanted to give kudos to the staff because they do an excellent job. And when one of the questions earlier about, does the staff push and do they help, kind of push the whole process along, I would say absolutely they do. They don't let us off the hook, if you will, and just start picking majors that are less important or have less weight. They also don't let us off the hook on pushing the bar higher and higher and higher, and reminding us that part of our role is to continue to move that bar up. On some of these measures, we've gone up 20–25%. So I would say we absolutely, every year the measures move, and it's rare that we would not move a measure. The actual percentage, probably PCPCH for many years stayed the same because it was a goal that was kind of a must-have goal kind of thing. So today, what I've been asked to do with Amit is really it's not so much the 2020 measure set, it's looking at the right side, which is the retired measure set, and explain to you why we retired those measures. First off, we had a lot of feedback this year from providers, CCOs, stakeholders. We did a survey, we got about 288 responses asking them questions about the measures. If you had your dream measure set, what would it look like? If you had your your ideal number of measures, what would that look like? And a lot of them were 10 and below. We had the lion's share of the folks wanted around 10 measures. We landed at 13, and as you saw, we added 4, but we removed 10. It was a lot of measures. In the history of metrics and scoring, we've only ever removed 5 total. So to remove 10 in 1 year is a big deal. So I offered to John to, I'd be happy to come and really kind of explain ourselves on these measures. And Amit, feel free to jump in whenever you want. I have no problem relinquishing the microphone for you because you always have great input. Did you want to say any kind of?
Thanks, I will.
Yeah. Did you want to say anything kind of as a starting point?
Yeah, I mean, I think the only thing is that I think, as Will described, there was a tremendous amount of feedback, from a variety of stakeholders. I think that gained experience of these CCO metrics over the years. We're getting better and better at trying to figure out, okay, what's the right set, what's the right amount, what are we trying to achieve? And so I think it's an evolution. And then I think, just like Will said, kudos to our OHA support team, because they continually bring a very, very deep bench of analytics and evidence and all the things that we need to put together from that angle. And then the last dimension is the committee itself is comprised of, I'm continually impressed of the expertise that's at that table and what they bring and the insight they bring. And the decisions are made are often they're hard, and there's pretty robust discussion and aggressive disagreement and alignment and collaboration and all of those things put together, which to me is a sign of a really, really healthy committee, and where we want this kind of work to be discussed.
Okay. So I'm going to go down each one. Some of them are going to be quick because you've already, with the other presentations and with just discussion, they've come up. And so I'll use the order in which is on this list. So starting with weight assessment and counseling, this was a measure we brought in originally knowing it wasn't an evidence-based measure. We did that intentionally, and it was a bridge measure, if you will, to an obesity measure. It has not stayed on to the bridge to when the obesity measure comes on, because as you saw in the results, everybody met it. It's kind of a standard of care anymore. EMRs all track it. If you aren't doing it, I'd say it's rare to find providers that aren't doing that. And so it was one that just didn't feel that it had the importance, if you will, compared to other measures that are emerging, to stay on the measure set. PCPC, and I'm going to just go through them, so if you want to stop me at any point, feel free. And Ahmed, if you want to jump in on any of them, feel free also. PCPCH, you saw from Chris's presentation that it's now incentivized in a very large way within the contract. We're required to support it, and we're required to pay it. And to have in our case, we have a very in-depth tiered system and pay based on the level of tiers that a provider reaches, and we pay it quarterly. It's pretty standard. Just so that you know, the results from a study last year showed that only half of the CCOs were paying any incentive dollars in the past or currently. For PCPCH. So in the contract, it now requires that full engagement from the CCO with the PCPCH program. So to keep it here actually would have double incentivized it. So the providers, the CCOs, the providers would really be double incentivized to keep this, because we had this in our APMs. So they were getting it as a requirement and then as an incentive. So that's the main reason we chose to remove PCPCH. We fully believe in the program. We also we had a pretty good increase in activity or in actual results, and so chose that it was time to move on. Any questions on that one? Number 3, so effective contraception use, and Ahmed, I might have you help me on this one a little bit. From the physician standpoint, but we started in at the 30% range, and the goal was 50%. I know in our market, a lot of folks thought there was no way we'd get to 50%, and within a few years, we've gotten to 50%. There's been a lot of concern around the inequities with this, and because it was a homegrown measure, the potential for disparities coming into play that were unintended. We've also had some, well, I won't go into the whole ethical part of it, but we have had some ethical questions raised about choosing this measure, because while we're reducing unintended pregnancies, there was question about, are we reducing pregnancies as a whole, and is that really our role? So I'm going to jump over to Ahmet and let him kind of speak on effective contraception for a moment.
Yeah, I think Will kind of put it. I think that we, because it was a homegrown measure, that's one of the things that sometimes makes it really difficult. The other part of it was, really around, some pretty very specific disparity and or inequity type of issues that were pretty serious in a various amounts of communities. I wanted to just add to what Will said, that response we observed in both rural and urban areas. So it was fairly across the board that was there. And then lastly, we were trying to ask ourselves, what was the transformative part that we were trying to gain by this measure if there were some concerns around some of the equity disparity and maybe even some ethical issues that were associated with it.
All right, moving on to developmental screening. Developmental screening is the one that we came in at about, when it was first measured about 5 or 6 years ago, came in at about 20%. And when we ended this measure, or when we decided to sunset, we're at 70%. There's been a dramatic increase in achievement on this measure. Oregon is the top performer nationally for Medicaid, and we really felt there was no room for meaningful improvement. We also were bringing in, as you see on the left, we were bringing in kindergarten readiness measures that we felt really helped to replace this by doing more child visits, and so we felt like it was time to move on. Any questions on that?
Yeah, and just to add to that, we felt the group felt that taking it once again to this other level of what do we want to achieve with pediatrics from a transformative level, and moving into the social emotional health space and kindergarten readiness and et cetera was really the direction that we felt as a committee, but also from all the stakeholders and input that we received.
Next one is, where are we here? Dental sealants on permanent molars for children. This one wasn't around very long. We didn't have it for many, many years, but we did start at 10% and then at around 24% over the 4 years. Sarah had mentioned it was a 34% increase. Part of it that got tricky on this one is there's only so many molars. If we have no turnover in the children in our network, there's only so many molars to seal, and over time it kind of starts catching up with itself. We also were looking at, I think for this year we changed the age because we were starting it at age 5, and really your molars don't emerge until kind of toward the end of your 5th year of life, and then going into your 6th year. And so it got to a point where are we just kind of hunting for molars, and so decided that it was time. We also then brought in the preventive dental visits. Originally, that one was only age 1 to 5, and so we added age 6 to 14 in order to capture that age when you would get sealants on your molars.
And I also think too that the sealants offered a really great launching pad for us to have a robust discussion around dental or oral health overall, and how do we use the metrics as one part to really address that across the age spectrum. So as Will described, the preventive part was included there along with the age adjustment, but then also just the oral health for diabetics, and trying to think about how we think of dental just beyond, to use Will, like hunting for molars only.
Right, next one is the caps. We used to have 2 caps, access and then also kind of satisfaction with your health plan. We removed that one a couple years ago, and then now we are recommending, or we have removed the caps for access to care. For those of you who don't know, the 2 questions that get counted in this survey, or in the survey is, in the last 6 months, when you needed care right away, how often did you get care as soon as you needed? And then the second one is, in the last 6 months, how often did you get an appointment for a checkup or routine care at a doctor's office or clinic as soon as you needed? It was getting harder for CCOs. We are always working on access. I don't know a single CCO that's not always trying to achieve greater access for their membership and making sure that it's timely and appropriate. beyond that, it was hard to know how else to impact this measure. I know for All Care, it kind of bounced up and down, and you could really, for those years that I felt like we had the greatest access and had no issues, were the years we had the lowest results. So it was really hard to know what activities resulted in the members answering these two perception questions in a positive way. We also had kind of hung around the 80% range with this one, and so decided that it was time to retire it. Just so you know, the committee has looked at other CAPS questions many times. OHA has done a great job of bringing their experts forward with different CAPS measures and tried to tie them back to a quality measure, and it typically felt like a stretch. It felt like we're trying to link follow-up between the primary care and the specialist back to quality that was hard. It was going to be hard again to know what activities resulted in positive outcomes from the patient's perspective. So we've struggled with, while we believe in CAPS, we've had a tough time really linking each of those perception questions. And remember, they're done after the year. So the questions are done asking them about the prior year. And so that's why we decided to remove that one.
CAPS is also part of the PCPCH process.
Correct.
And so,
yeah, they're required to do it. Yeah.
Right, and so essentially that will still
Continue to
continue
go on, right.
through the value-based payments.
Mm-hmm. Yep.
And I'll just say from a prior experience, I know, not to say it's not important, but there's a lot that goes into why somebody might answer a particular way. When I was at Kaiser, I think we really dove in to try to understand, and you run into things like people didn't get the exact appointment they wanted, they got their second choice appointment or things like that,
Right.
that, how the question's sort of perceived and why people, how patients are, what exactly they're responding to is kind of hard to.
Well, each one of us at this table have a different perception of what timely is, as far as getting an appointment with your own doctor. So, then you're basically saying to every member what you consider timely to get into for an appointment, and it's tough to judge that. All right, moving on. The ED utilization. This was the general ED utilization measure that we've had for many years. And we had reduced it to such a point where we were best in the country most every year. And when we brought in the SPMI measure around ED utilization, it made so much more sense to focus the energy there, because we hover around the 40 visits per member, I believe it is, or 40 visits per 1,000 members for ED utilization. And whereas with the SPMI population, we're in the 90s. And so if we're able to really impact that and help the SPMI population reduce those ED visits and get them back into primary care or get them into the proper setting, we believe that number will automatically drop, because the real disparity or the real outlier in ED utilization is the SPMI population. Ahmed, did you want to add anything with that?
Yeah, I just think once again, that was just, the evolution of this generalized ED measure and all the good work that went around doing it, and then us really trying to think about how do we transform and really address inequities and disparities that we all know are the drivers of the utilization issues that we see, and that the care that happens in the ER for these individuals, of course, is great, but it's just not the appropriate care that they actually need. And getting folks to concentrate on that work is absolutely critical. And so we just felt like, once again, it was another great evolution of the measure to take it to the next level, addressing disparity and inequality and real utilization issues.
Next one is adolescent welfare visits. Had that one around for a long time, started in around the 20% range and ended in the 50% range. One of the tough parts on this measure was that it went up to age 18, and getting that 16 to 18-year-old group to engage in, was it 18 or 21?
21.
21, sorry, I knew I was out there somewhere. Getting the 18 to 21-year-olds to go to their pediatrician or to go get a well child visit really became, or an adolescent well care visit was tough. If we wanted to stay within the standard measure within the country, and so we kept it at the 21, but it was really tough. I don't know, you know, if you think back to when you were 18 or 19, the last thing you wanted to do was go in and get a well child visit. So.
Question, I could have asked it on some of the other measures, but I'll pause here. I'm certain the committee talked about losing traction on some of the measures over time. So if we're no longer incentivizing, are they still on the watch list? And if so, do we imagine measures much like this one might reemerge in the future if we see
that's actually something, you know, obviously I won't be there, but the committee has talked about like colorectal cancer screening, which we'll talk about here in a minute. You know, do we bring it back as a disparity measure when we have enough data to be able to do that? Do we bring it back as a different type of measure with especially with a disparity twist on it that, you know, really study the data and say, here's where the real issue is, like ED, you know, the issue is SPMI. So let's focus our energy there. So yes, that's something that we've discussed. Yeah. Because again, none of these were bad measures. They're just, you know, they're either seeing their time or making room for new ones. And you know, quite often when we took one off, we only added one or two. And so this does give room for more new measures.
Make just one comment.
Yeah, and I also think too, like, you know, we don't want the measure set to ever be in one regard completely static. So, you know, there is continued information. So, for example, at least once or twice a year, we get phenomenal public health, you know, presentations and information. There's various work groups that are going on. There's a whole surveillance that's going on around, okay, what's going on for the quality of care, and for that to continue to hope, and then just like I think that was Brenda who was asking that. You know, I think just for that, there are specific measures that are watched and continually measured still, despite not being in the incentive program, so that if you do see some things, you know, kind of go off the rails or lose or slippage, then that would be able to come back and have folks really address that again.
It's great explanations for a lot of these measures, and either some of them are dropped or kind of duplicated elsewhere, like PCPCH. But I guess the combination of dropping effective contraceptive use and adolescent well care visits, which from just my perspective seems like, those don't seem great to do at the same time. So I just want to underscore that I know the effective contraceptive use is on the like kind of watch metric, even though it's not going to be an incentive measure anymore. And I guess I'm like, when will this watch list come back to the Health Policy Board? Maybe
Yeah.
you'll be on.
Yeah, that would probably be best. Yeah, I mean, it's something that we're always continually looking at older measures and looking at, you know, re-emerging measures. We also, though, remember we are now with the new, you know, setup, we rely on health and quality metrics for that measure set. So some of these, you know, one of the processes that we kind of didn't explain is that there is a process where if metrics and scoring, because we've been doing a ton of work over the years and we have presentations all the time on different opportunities with public health and with, you know, obesity and with all the different work groups. One of the processes we do is we make recommendations up to health and quality metrics to consider, you know, here's a measure. So as an example, we may in a year say, hey, we'd love for you guys to look at colorectal cancer screening as a disparity measure. Here's the specs we're thinking about. Here's the parameters we're looking at. Could you consider it? Sometimes Amit and I would go and make a presentation. When we're making recommendations on work groups, so the kindergarten readiness, we went through a whole process where we went and made recommendations to them. Here's our vision. Here's what we'd like them to accomplish. They approved it. It went forward. It kind of, you know, they did regular updates to both groups. So there's kind of a formal process that we've set up that's worked very well for that. But it needs to go back up to them to approve, to then approve for our measure set to be able to choose from it.
So I just want to do time check. We have
Yep.
about 10 minutes.
Yep.
And Kirsten, I point out on the 2020 incentive measures, there's immunizations for adolescents.
Right.
So
That's
hopefully
what
at that
Mark
visit
Reed
we'll
brought in.
capture that.
Immunizations and well child visits, and I mean, we have, you know, we're trying to make sure that things are you know, we're always looking at the scope of children, adults, chronic diseases, you know, so we're not just looking at it from just individual measure, but kind of a well-rounded measure set, which is what also health and quality measures does. So, moving on real quick here to colorectal cancer screening. So this one, we started in the 40s, ended in the 50s. I think probably the most, this wasn't barely passed to be removed. I would say the most obvious reason that this came off was because it's a standard of care. Doctors routinely know that at age 50 you should start, you know, requesting people to get their colorectal cancer screening. And I just think that that was probably the biggest compelling reason. We hadn't seen a big improvement over the last year and decided to take it off. It doesn't have, as some of the others, as compelling of reasons we took it off, I'm going to be honest. John was quite surprised when we took this off.
I'll say that.
Yeah, okay. And then the last one is controlling hypertension. This one was started in the low 60s and ended just over the 70s. Many of the CCOs had hit the 90th percentile for Medicaid. And you know, when we hit 90th percentile in Medicaid and then start moving in, the next step beyond 90th percentile in Medicaid is to go to commercial. And my thought is when we start moving from Medicaid to commercial, isn't it really time to allow another measure that might be like we did with postpartum care, where we were way below the national standards with postpartum care? So, you know, we were hovering in the 90% range with prenatal care. Isn't it time to make room for a measure that is suffering, if you will, and really start moving that one forward? So that's where some of these, it's making room for, you know, we've hit the best we're going to hit, unless we're going to take it to a whole nother level and develop a whole new structure around it. So isn't it time to retire it and bring something out that may have more impact for our population? That's been our logic with a lot of these.
So I think, Will, the last argument there was important. I mean, low-hanging fruit is easier to improve than, you know, the last 20 or 30%. I think the challenge here is optics. I mean, I was very bothered by the colorectal cancer screening measure. I mean, it's the second most common malignancy for men and women. There's ethnicity issues. But then if you look at it, the denominator, and I'm looking at Sarah, is about 6,000 people. There's not a big population here. Actually, when you look at the number needed to screen, you have to screen 300 to 400 people to save one life. And if you look at the rate we're improving, and I think there's still room to improve.
There's still room.
If you look over on the commercial side, they're up at 70%. We're at 58%. There's still room to improve. But it's going to be slow. If you look at the commercial improvement, it's 2% a year. And you know, I get screened by Kaiser. This is my screen. There's nothing in here. But you know, the colonoscopies are going on. And this is a different culture. But you're talking about incenting a lot for one life, to be honest. Hypertension, though, there's 125,000 people with hypertension in the denominator. And so at a 70% rate, there's 36,000 people in play. So I agree with all of these. You know, I just want to make sure that you all have some understanding and know that we're making trade-offs here. You know, there's 1,800 foster care children.
I think one of the discussions, and I think we've had this before, is the positive impact that we can make for all of our patients when we have these. So when we put these things in place, like the colonoscopy, we don't just say, oh, we're going to focus on these 6,000 patients. We do it for all of the patients within our clinic and with care, because from an ethical standpoint,
you have to.
You know, you need to do that. And so I understand what you're saying, but at the same time, I think if you actually look at the impact beyond Medicaid, it can be a huge impact. And so when you take that off, it's not just those 6,000 patients. The hope, of course, is that with the reinforcement of a process that has become a standard of care.
Right.
And I think what will be interesting and why looking at those measures to watch will be good to have follow-up is to see if it truly has become a standard of care. And so that's the question. And so I'm sure that as these decisions are being made by the committee, that they're thinking about that population health, essentially population health impact that they're having for all Oregonians.
So one last thing I'd like to bring up that's not on the agenda, but as I'm departing my chair role with metrics and scoring, one of the things that happened when Healthline Quality Metrics came in was we requested that the chair of metrics and scoring be a non-voting member at Healthline Quality Metrics. And we were told basically we don't see that that's necessary, and I understood at the time that it was a brand new committee, and so it was denied, and I chose personally to still go, and I just planned to sit in the audience and just listen, and if they had a question, I'd be happy to answer it. They brought me up to the table, let me have a seat. I don't vote, but I'm at most of the meetings. I've been at most of the meetings. It's been very, very beneficial. John's been there. There's times, especially in the early phases, when they would bring up something that we had already done a whole process on, spent a year doing, and I could say, wait a minute, that's already been done, and let me tell you what the outcome of that was. It was very, very beneficial. So I guess I would request that you consider that the chair of metrics and scoring be allowed to, kind of officially be at that meeting, because the conduit, you have to remember there's somebody on the board, on that committee, that's a voting member from Pabinoa. So to at least have the chair be able to be there as a non-voting member, I think is an important thing. It was, I think, very beneficial. That committee felt it was very beneficial, and metrics and scoring felt it was beneficial. So, Amit, did you have anything you wanted to say before we end it?
Yeah, I just echo what Will's saying, because I think it's really critical to, that in-person participation, not necessarily have to be voting, but just offering an ability to have alignment, especially as we get into these spaces of defining, for example, what does a transformation mean for a measure? Those kind of conversations and stuff, it's always better, I feel, when folks are able to participate together and design it collaboratively and keeping it aligned so that, work is being done the most efficient way, and the messaging as the work comes out of it is also done efficient and clear to the network and the providers and the communities that are working on these measures specifically. So thanks.
So just a quick closure question around there. What's our process to move something like that in structure for the Healthline Quality Committee? Is there anything formal that we need to take in order to make that happen?
I don't think so. I mean, we probably need to go back and take a look at if there's a charter for the committee, but we need to adjust.
Yeah, I don't think there's anything to do.
Shall we take it up in December?
Sure.
Let's start
Or
checking
I can
things.
so move, depending on Madam Chair.
Yeah, so, let's just check all of our things first.
Yeah, thank you.
Well, thank you.
Thank you for your service. We greatly appreciate it.
My pleasure.
Yeah, thank you, Will.
Yeah.
You're welcome.
So, all right, so don't forget our meeting next month. Mark your calendar for Monday, December 2nd, all day, half day on December 3rd. And I'll see you then. Meeting is adjourned.